Good afternoon. I hope you all are enjoying your lunch, and I'm sorry to interrupt what I know are some really stimulating conversations, having been a part of a few of them. I'd like to welcome all of you to today's joint event between the Duke Margolis Center for Health Policy and McKinsey & Company on why consumers are crucial for building a sustainable healthcare system. I'm Mark McClellan. I'm the director of the Duke Margolis Center for Health Policy. You're going to hear in just a few minutes from Shubham Singhai from McKinsey, who's led our collaborative efforts with McKinsey in this area. We have done one of these events before. We find them to be pretty effective in bringing together both policy perspectives and business strategy perspectives around key issues facing our healthcare system and healthcare innovation and reform around the world. And we want this to be a very discussion-oriented and strategic conversation about these key issues related to consumers and the future of our healthcare system. You're going to hear from a range of expert perspectives today and have a chance to contribute to the conversation. Again, the goal is to go below the surface and look at some of the deeper trends and factors that can influence those trends in getting to a much better, more effective healthcare system in this country and around the world. And to start that off, I'm going to provide a bit of the policy context, and you're going to hear from our collaborators at McKinsey about the business strategy and about some broader trends in which those strategic initiatives that businesses are undertaking fit. But just to start, as you know, there is growing interest in consumers playing a bigger role in healthcare reform. We're headed towards healthcare that should be more personalized, more convenient, more focused on addressing healthcare problems before they develop, which means more of a role for consumers, getting the services that they need and want in a more convenient setting, often at their home, and then taking steps to head off medical complications before they happen. That's not been the traditional approach of a fee-for-service, more reactive healthcare system. So we are headed in this direction, but it would be nice if it was easier. And that's some of the issues that we're going to talk about today. There is a lot of interest in consumers playing a bigger role, as I said, but we haven't yet aligned their ability to control and even understand what their healthcare expenditures are, let alone influence them in a more substantial way. This is very important from a public policy standpoint because, unlike many other industries, a majority of healthcare spending, even in the United States, goes through public insurance programs that have regulatory structures and legislative constraints on how they operate, and that have been the subject of a lot of recent debate and interest in reforms to support bigger roles for consumers, but also have been areas where there are some challenges involved. So we're going to talk about that. Public insurance programs, initiatives to promote price and quality transparency, and very significantly, the changing world in terms of consumers having control over their data from both public programs and private programs. So this is a top priority for the current administration. I don't think I need to tell people in this room how much the HHS leadership has highlighted the importance of consumer leadership in driving healthcare reform. Secretary Azar has a couple of quotes that I've put on this slide with getting to patient-driven care and market-driven reforms as being central to his goal, one of his top goals of achieving higher value-based care and to making more progress on addressing topics ranging from drug costs to opioid abuse and behavioral health issues. A lot of emphasis on consumers playing a bigger role here. Not that what goes on the provider side is unimportant, but this is a shift, a fundamental shift away from a primary emphasis that we've heard over the last few years around provider payment reforms and incentives for providers. Again, not that those are unimportant. Those changes in payment are important, but an emphasis on the consumer side of this, the benefit design, the out-of-pocket payments that consumers face in trying to move towards higher value healthcare systems. And along with that, HHS has prioritized giving consumers greater control over health information. I'm going to end on comments from that, and you're going to hear in a few minutes from Don Rucker, who's at the center of implementing these efforts at the Office of the National Coordinator for Health IT, with the idea that if consumers have more control over their data, they will be able to have more power to drive the quality and the cost effectiveness of care that they would like to see. So we're going to talk about that topic as well. Now, this interest in consumer leadership and healthcare reform is not new, as I said. It has been growing. This is a summary of some of the kinds of information that are available to consumers today through states and through similar versions of public information from the federal government to help people better understand prices and quality of services. I've highlighted here a couple of states like New Hampshire and Maryland that provide across all payers information on the total costs of care, the total payments for care that consumers can expect, and to some extent their out-of-pocket payments for a range of services and even some common conditions, like in this case knee replacement prices. And this is something that the private sector is very much expanding as well. This is an example from United Healthcare of their consumer-facing tools. These are available now online and on smartphone apps to help people make choices about price and quality of care, with information here on total out-of-pocket payments, total costs of care for, in this case, an elective knee MRI. And this is also starting to fit into new benefit designs where consumers get some opportunity to save more when they go to providers that do better in terms of these total cost of care measures and quality measures. But I do want to emphasize that we have a ways to go. A lot of the information that is available is based off of specific fee-for-service prices, maybe not even the actual prices that beneficiaries in a particular health plan that's negotiated particular rates with providers are actually going to pay. Moreover, these individual fee-for-service prices, while informative, are awfully hard for consumers to put together when they are getting care for especially a complex condition, one where there may be multiple doctors involved, multiple services involved, an entire stream of care. So that is a challenge. In addition, some of the tools and supports that can provide broader insights for consumers may not be viewed by consumers as all of that complete or relevant. A group that we also collaborate with, the Coalition for Payment Reform, has been a leader on getting consumers and employers more engaged in smart purchasing decisions, gave 43 states a failing grade for the quality of information that they make available to their residents about the quality and prices of services. And that's generally because either the information is not available across multiple payers in the state, or if it is, it's limited to just a limited number of services, limited set of charges that may not be relevant for particular patients, and of course a limited amount of quality information. Moreover, the quality information, the quality measures that are available to consumers today are quite limited, especially when you get to the kinds of information that consumers with particular health problems would like to know. How likely am I to have a good outcome after my knee replacement? What is the quality of an MRI performed by this health system versus another? And especially if I've got a very serious condition, cancer, major heart disease, and the like, what healthcare providers are going to help me get the best possible care for me or for my loved one at the lowest possible cost. The quality information available to support these kinds of decisions still pales in comparison to what consumers usually end up relying on now, which is word of mouth or relying on their provider still. We have a ways to go in terms of real transparency. And then finally, for most healthcare costs, the decisions that are made are occurring at a level that goes beyond any opportunity that consumers have to share substantially in the savings that they might get from actually choosing and getting better quality care at a lower cost. It is true that high deductible health plans are continuing to grow. The dark purple part of the chart and the green part of the chart at the top kind of summarize some of the growing shares of high deductible health plans, those that meet the minimum requirements for federal requirements for substantial consumer skin in the game with their benefits. And you can see that these benefit designs are really becoming mainstream, so the main kind of health insurance that consumers are enrolling in these days. But within these plans, there's a very uneven distribution of healthcare spending, reflecting the uneven use of health services within the population. So this is from Peterson Kaiser's Health System Tracker, which highlights that even in this population where a growing number of people are in high deductible health plans, only a small share of them have high expenditures. But on the flip side, the vast majority of expenditures are occurring at the top end of the spending distribution. So the result of that is that for many people who are in high deductible health plans, there is potentially an impact on the services that they choose. These are people whose typical use of health care in a year might be a doctor's visit or a limited set of encounters with the medical system and maybe a few prescriptions. And that's why drug pricing is such a big source of public interest and public policy concern right now. But the vast majority of spending does not involve those individuals. Involves individuals who have been admitted to the hospital, who have a serious medical problem leading to the need for chronic treatment, including with drugs or other more intensive interventions. That's well over half of expenditures are by people who, even in a high deductible health plan, are going to have spending way over the limit, total spending way over the limit, and their own spending is going to be at the out-of-pocket maximum. And what that means is if they take steps to try to reduce their health care costs, they don't have necessarily a direct way to benefit financially from those steps, and their plan may not be designed in a way that really encourages that consumer partnership to try to get healthcare costs down. Overall, consumer spending is around 11% of total healthcare spending. And it's designed in a way where, especially for those patients who have higher healthcare needs, there is not much, at least direct financial benefit that they have from choosing less costly care. Just to give you a contrast for this, in an area where I had a chance to work at CMS in services for long-term care for patients who had disabilities and needed over time, back in the 1990s, Medicaid benefits for long-term services and supports were really designed around providers. So there was an entitlement in the law, there still is, to getting care from a long-term care institution, a skilled nursing facility, which works well for some patients, but for many, they'd prefer, especially with modern technologies and support systems, to live in the community, maybe have some home modifications, maybe have some part-time assistance, maybe rely on automated services, even robotics, remote monitoring, things like that. Well, that's not traditionally what Medicaid has covered. So we started a pilot program called Money Follows the Person that gave those individuals an amount of support that they could use for their long-term services that they controlled. It was adjusted based on their degree of functional impairment, the amount of supports that they needed. They had guidance from the federal government and especially from states that adopted these programs to help them match up their needs with technical and other supports in their area. But the point was that they controlled the expenditure. So if they found less costly ways to meet their needs, they got to share in the savings and they got to share in the benefits and getting the kind of care that they wanted, and the states and the federal government did as well. So that's a consumer-directed version of benefit design. Now, we haven't seen that so much yet for most acute care services, for most of the medical services that account for those big costs. That's starting to change in both federal programs and private insurance programs as well through steps like value-based insurance design. So the Center for Medicare and Medicaid Innovation has undertaken a broad array of payment reforms that are designed to align provider payments to healthcare providers with the value of services, not the volume of services included. These include episode-based payment reforms, primary care payment reforms that are more about per member per month payments tied to some accountability for quality and overall costs, accountable care organizations, all steps in that direction. Those are all programs that are directed at providers, where if providers get more flexibility, is at least the idea, in how they deliver services, and if they can do it at a lower cost and get better outcomes or better measured performance, then they have new flexibility to support those kinds of care delivery models. Those models in general have not been extended to patients. Most of the payment reforms that have been adopted for providers are ones that are occurring without patients not even necessarily knowing that they've been enrolled in one of these programs, let alone having opportunities for financial or other benefits from participating in them. That's starting to change. This is the one CMMI pilot that really focuses on value-based insurance design in the Medicare Advantage program, which is expanding significantly across states and expected to be in all states by 2020. But right now, only a very small fraction of even Medicare Advantage beneficiaries are participating in programs like this. It's about 2% today. These plans have started to provide value-based insurance design for 6 major conditions. Under recent legislation, they can expand it to a few others. But as you can see, very limited opportunities so far, at least, for Medicare beneficiaries, including Medicare beneficiaries who are not in the Medicare Advantage program, to gain when they participate in new care models, especially for chronic and costly diseases that can lead to better outcomes and lower costs, at least not opportunities to gain directly, either through additional benefits or lower out-of-pocket payments. That can and probably will be changing in the years ahead. Another CMMI, or another now Medicare reform that is consumer-directed, one that focuses on behavior change, is the Diabetes Prevention Program. This, too, has been set up as a new payment model for providers of services to help people with diabetes, in this case, manage their risk factors. And it turns out that in this program, perhaps not surprisingly, interventions that help through community-based programs like the YMCA that help participating individuals modify their diet, their exercise behavior, maybe their adherence to medications, can have a big impact on outcomes and potentially on healthcare spending as well. This pilot program was expanded nationwide, so it's actually a Medicare benefit now. But it's primarily or entirely set up focusing on providers. So physicians and the associated healthcare providers in this program get a payment for enrolling patients and working with Medicare beneficiaries in the program. They get an additional payment if the beneficiary has a significant response in terms of risk factor reduction for the complications of diabetes. But from the beneficiary side, there is a benefit, obviously, to being able to participate in this and enjoy some of the health benefits from it. But from a financial standpoint, from the standpoint of additional services and supports in Medicare, it's not really targeted directly to the beneficiaries in the way that a fully integrated consumer and provider-focused set of reforms might be. So those are a few illustrations intended to highlight some of the challenges in moving to an even more consumer-engaged, high-value healthcare system, building on some of the reforms that are taking place on the provider side. You're going to hear from Charlene Wong a little bit later today about Medicaid reforms that are moving in the same direction. Some of these focus on copays, but again, as hopefully is clear from my comments, just the copays by themselves are not enough to necessarily drive major changes. Copays can, as the evidence has shown, help influence whether people decide to seek care or not. But again, with most of the expenditures coming from people who have significant medical needs, the decision about whether or not to seek care is probably not as important, or at least other decisions are equally important. What kind of care do you seek? How effective is the care system that you're using? And are there aligned financial, regulatory, and other supports for both the consumers and the providers involved in these systems to deliver the best possible care? So far, evidence from these programs in Medicaid is early stage and limited, and again, suggests some room for improvement. Finally, I wanted to end with an even more positive note about how all of these directions, I think, are going to be reinforced and continue to change in the years ahead. HHS recently made a set of important announcements about shifting the focus. Instead of relying on providers and providers sharing data and doing analysis to support better care models for patients, shifting the focus more directly to consumers. We're very pleased to have Don Rucker with us today to discuss these new initiatives and what some of their implications and maybe challenges in implementation may be in the months ahead. Among these are the Medicare Blue Button 2.0. So Medicare has made it possible through Blue Button initiatives since, I believe, 2011 for beneficiaries to get access to their data. Historically, that's been in kind of spreadsheet or PDF format. Now, thanks to the, not magic, but real progress around open application programming interfaces or open APIs, it is possible for Medicare to support applications that pull these data directly into consumer-facing tools. It can be used on their smartphone, can be used potentially by their providers or other people involved in their healthcare delivery to get access to their data in a much more timely way. And maybe coming would be similar kinds of timely and very efficient access for healthcare providers who are involved in their care. Maybe getting back to that alignment between the provider payment reforms I was talking about earlier and the consumer reforms. There also are some steps that may be coming around penalties for companies that aren't getting with the program. So this is something that Medicare is doing. But also steps that Medicare has called on private insurers to follow, to liberate data for the patient, to enable them to control more of the information needed to get the best services at the lowest cost and really drive some of those changes in payment, in benefit design and care delivery that I was talking about earlier. Same kind of thing happening in terms of using open APIs to get access to data from electronic health records. Apple had an announcement earlier this year with 12, I think it's now 13 healthcare systems saying that they're essentially doing the equivalent, making it easy for consumer-controlled apps and maybe down the road other providers and systems that consumers are working with to get access to their electronic information in a way that's relatively straightforward to use. So we are at a very important time in this shift to greater consumer-driven health care as a result of policy changes. The administration has made this a high priority. I've hopefully made clear that there are some foundations to build on for more consumer engagement in public programs and in the regulation of private programs. There are new steps that can be potentially transformational in terms of the role and access that consumers have to their data, but we haven't yet fully capitalized on all of these potentially transformational benefits, and that's why we're meeting here today, to take stock of where we are with these policy changes, as you'll hear from in a minute, take stock of what the market and business environment looks like fitting in with the trends and the important new policy developments that I've just described, and what we're going to do about it. So you're going to hear first about some of these market trends from my colleagues at McKinsey. Then we're going to talk about the evolving role of technology and data with help from Don Rucker. Then we have 3 panels, one focused on consumer engagement innovations that are happening outside of the U.S. A lot of interesting things happening in the non-U.S. context. Then a panel on making consumerism work, addressing some of the challenges that I've outlined here and others as well. And then finally, panel with national leaders on value-based insurance design to discuss what the next opportunities are in that area as well. So that's an overview for the day. I'd now like to turn to our next framing presenter. Shubham Sanghai is the senior partner at McKinsey who leads the firm's global healthcare practice. I've had a chance to work with him over the years on some very important work related to healthcare institutions and the strategies that they're undertaking. He's done extensive work on corporate strategy, growth, mergers and acquisitions, business building, large-scale performance transformation. I know he's been very busy recently with all that's happening in the healthcare market, and he's going to provide an overview on some of the underpinnings of a successful system and the enablers more from the private sector side to complement what I've described from the public side. So Shubham, if you could come on up. Thank you.
Thank you, Mark. Welcome, everyone. I just wanted to share, maybe in the next about 10 or 12 minutes, just a few thoughts that we would have from the research we've done and as we see kind of the world of the healthcare consumer evolving. So a couple of things on this. Overall, as we look at the healthcare system, I mean, a lot, I think, as Mark said, has been done to work on the provider side, if you will. But at the center of it, when we really kind of look at it and understand the healthcare consumer, there is a very large number today, right? Many times people say, well, you know, where is the consumer? There's a very large number of people buying their own health insurance today. So that we know, you know, kind of directly puts them accountable for making those choices, understanding them, and playing, making those decisions, and then having to live with them when they have to use healthcare. There's 59 million people now. Mark showed this on high deductible health plans. Most of them, as Mark showed, actually spend money. They give the money for the premium. And any other need that they have, they essentially pay out of pocket, right? Because the deductibles are high enough that the insurance plan actually doesn't pay for a lot of that care. We also have seen 9% compounded annual growth rate in what the average annual health plan deductible is. We all know the wage growth is nowhere close to that. So clearly, the rate at which the exposure has increased for consumers has risen quite dramatically. And then if you really put together out-of-pocket, but also what consumers are actually funding the healthcare system, you know, they pay for about 28% of that. And so if you, in many Byzantine ways, as Mark said, so the real kind of question then is, if that's the consumer, they have a right to be a lot more demanding than you know, what the industry is delivering. Now, let me break down a little bit of where consumerism is today. It's probably in the first or second inning, if we were to really kind of think about it. It's a very, very long way to go. So if I just take a look at where we are today with this, there are two kinds of things that have happened. One, Mark touched upon with consumer cost sharing, high deductible health plans and the like, pretty blunt instrument. The second is what we would call kind of pricing of choice, and particularly set off by the public exchanges was a trade-off on access, essentially the breadth of networks with the price that the consumer was paying. And there was a lot of talk when the exchanges came into being, whether there'd be a backlash. But there has been a set of choices that consumers are making. Couple of quick things, and I'll breeze through these quickly, given Mark touched upon a lot of the cost-sharing aspects. If you just look at the actuarial value of plans, and you look at what is the utilization that people have, and this is total allowed, not what the plan pays. So the utilization clearly goes down. Now, it goes down a whole lot more when it goes from being free entirely to having some skin in the game, and then it sort of flattens out towards the end of that again. Because as Mark said, you can keep increasing cost sharing, but at some point, it's the people who end up having the really severe events that are spending large sums of money, and at some point that care just has to be provided. So it's a blunt it's an important but blunt instrument to just have added cost sharing. Now, oftentimes people say, look, where is the change actually happening? One of the things what this shows is we looked at, there are consumers that buy health insurance with a view that it's a prepaid plan, I want to use it, and those that buy it for financial protection. And if you look at it in both of those cases, the behavior, when you increase the deductible, changes a lot. Of course, it changes a lot more with those who bought with the intention of using care. So it does dampen a bit of this moral hazard issue that exists within healthcare, which is, if you providing insurance does induce utilization. And now some of that utilization can be good, some it can be bad, so that's always an issue when you raise utilization, whether you're just dampening it and it's going to pop right back up. So that causes an issue that we have to worry about. But in general, if you look at it, there's a fairly meaningful difference. The second is the trade-off, and the public exchanges in particular provided us the experiment to be able to see how consumers would trade off price with access. And if you look at the range of health plans that were provided, less than half were with broad networks, which was almost all of them were broad networks prior to the ACA. And there was some with ultra-narrow networks. This is sort of less than 30% of providers in a local geography included in the network as covered. And so people were buying a fair number of fairly restrictive in terms of access plans. And the price differential has been quite significant as well. We can kind of go into, but every which year, one of the years, double-digit differentials in pricing between the narrower networks and the others. And generally over time, as the claims data has come in, supported by differentials in kind of the cost structures as well. So that's kind of the second part. If there was cost sharing, there was a second part on access and pricing that access and understanding what people are willing to pay up. Or get lower at 18% to go in silver to a narrow network plan, or those that bought the broad to actually pay up to buy the broader set of networks. So the real question is, okay, so we've done that, and we see some difference happening, and some people that want to have just protection and want to therefore have cost sharing have sort of done that, and maybe we'll keep moving a bit more. Some people who've traded off access. So what else, right? We're sort of just kind of looking at this at sort of a very gross and average level. Both of these are rather blunt. If we look at it, and I'll talk a little bit about these, there are three kinds of things that are beginning to kind of play out, but haven't really, and that have to, if we are to really unleash the power of the consumer. The product design has to go well beyond just adding to cost sharing. And that's a big one, and let me kind of get into that. Second is the design of the delivery system itself has to become a lot more patient-centric. It's beginning to happen. There's a lot of growth in that direction. I'll show a bit of that. And then third is the promise with digital means of interaction, artificial intelligence, and the like. What kind of care pathways and ways that consumers can be unleashed and enabled to kind of manage their own care could we actually see? The first is if we were to look at product design, and we said, look, we're not just trying to dampen utilization, but what we're trying to do is to essentially drive value-conscious consumption. On the supply side, or the delivery side, drive value-based care delivery, and then unleash a consumer market where you can in the delivery side. Which, one would argue for a personal consumer service, we don't really have a real consumer market for a lot of services. Some of you probably seen this. The research that we've done is, it's quite important when we take $3.5 trillion of spend to break it down by whether it is, random, infrequent, catastrophic, and unpredictable, and really not controlled by the consumer, versus things that are within their discretion and able to make actual choices around it. And when you break down kind of the severity, frequency, the level of discretion, and whether it kind of continues over time, you get everything from routine, which is the sniffles, to end of life. But the big differences here are, when you have the number 7 there, catastrophic, not chronic, this is the classic, a bad event happened. And in that instance, when we've done cost sharing and we say, hey, we're going to put cost sharing on you, it's unclear what value we derive from that cost sharing. What is the person going to do differently if they had a bad event, an ambulance picked them up, they took them to a particular place to get treatment? There's no level of discretion, nothing that they can do. And in fact, with cost sharing, we've created underinsurance as a result. On the other hand, if we look at a lot of elective and discretionary items where they may not be evidence-based to say that one expensive treatment is better than the other, we could put a lot more back on the consumer to say, well, it's your choice to deploy your money from savings, which could be HSA or otherwise, and how do we kind of think about that part of it? And if we break it down, here's kind of where it looks like along those categories on whether the consumer has discretion and the ability to absorb the expense. Some of these expenses can be large. And if you were to take that view, you would say, look, the financing model, the benefit design, if you will, that I would create, and the payment or reimbursement model I would create is actually quite different for each one of these. I won't go through all of these, but if I were to take a couple, again, second from the bottom, for the catastrophic, which is not related to chronic, that's what insurance is designed for. Something really bad's happened, insurance should pay for it quite a bit in full. And really the question then is, because it's most likely an acute care episode, is how do we make sure that the provider actually provides high quality care? We don't get the readmission. We actually get the right quality where the person comes out and the recovery happens well, et cetera. What's that episode of care for which we should reimburse the provider? Because in this case, the provider is the person that has more ability to be able to actually control that care. On the other hand, if we look at chronic care, yes, it's insurance the way we have it, but as Mark talked about, if a person does better in managing their own care, if they are adherent, how do they benefit and share in those savings? How do they get incentives to be able to be able to participate in the benefits that accrue from their own behavior, leading to better outcomes for them and overall in terms of a cost standpoint? So those are some of the choices. Now, the other part is how do we unleash a consumer market? The evidence is scant in healthcare, given we cover a wide range of medical services. So really the things that you find are a little bit in the cosmetic world, if you will, although LASIK eye surgery is as complicated and as involved as many other kind of procedures that you would find. And it's interesting to see that when these things are not covered in our insurance system, they actually have shown over time, and consumers are making the choice, they over time have shown that they've actually gotten cheaper. By the way, more people are getting these procedures. The quality is not gotten worse as these things have gotten cheaper. They in fact have gotten better, but they have gotten cheaper. That's not something that happens in everything that we cover. And it's a little hard to understand why that might be the case. And a good part of it is because ultimately in a consumer market, if you have to stay competitive, you have to deliver more value every year, every time, or some other competitor will take your lunch away. That's just the nature of the beast. If Apple doesn't come out with a better product, Samsung will sell more, and Apple therefore has to innovate. That dynamic in healthcare doesn't quite exist because the consumer, again, is not able to fully exercise their ability. We looked at this on real claims data, and we said, look, if we applied a next generation of product design, and we said, look, if we were to take a lot of this routine and elective and essentially make it a consumer market and let them unleash the kinds of effects we see in other consumer markets, and then if we were to apply a number of things with different payment models, et cetera, and create intelligent benefit design and changes, we would actually end up with products that are 40% cheaper than what we have today, in just being able to apply some of these things, in unleashing the consumer, in making the choices that create a competitive consumer market for services, making the choices where the benefit design is geared towards sharing of incentives where they can do something about it, in fact covering more where they can't do anything about it. That would create that kind of a model where you could create a whole lot more a whole lot more savings. So that's kind of on the design of the benefits. Now, the other side of this is the delivery side, where you've all read a whole lot about how our system grew up as being very hospital-centric, and then hospital systems add a series of services around that are not necessarily acute, that they kind of play with then. The question is, the consumers are demanding more convenient options. Our research kind of shows most of them want more convenience. If you look at what kinds of things they would prioritize and the choices that they make on their own care where they can, it's convenience and access are the kinds of choices that they would make. And it's sort of no surprises to some extent that retail clinics and urgent care, et cetera, have been growing quite fast, small base, but they've been growing quite fast as we look at it, as well as ambulatory and the like. These places are cheaper. If you look at standalone labs, or you look at treatment for a number of things that you can get in these alternative and more convenient settings, they are actually less expensive. And oftentimes, if you get underneath it in ambulatory surgery, we actually find both the labor and capital productivity is quite a bit higher, which means they are not only cheaper, but they're actually more profitable for those that are providing this, because they do a particular type of procedure, do a lot of it repeatedly, and they're just more productive. And so, how does where might the model actually go if we look at it? If we look at it with vaccinations, a whole lot of that could move. And when we look at it in our research, and so many more people, it's a lot more convenient to walk in to a CVS and get that versus get your physician appointment. You look at labs where you can actually get the collection centers, again, all of that increasingly going retail. If you look at the partnership Walgreens and LabCorp are creating and the like. If you look at a lot of minor procedures, this all also doesn't require hospital-based care. You can get a lot of this in urgent care and the like, where minor procedures can be completed. A lot of specialist consults. It's increasingly, particularly with telepresence, et cetera, you're beginning to get where there's a lot more that can be done, remotely, frankly, with e-consults and the like, that is actually quite effective, including some of these things with remote diagnostics, where you could be with a nurse, but they can do the diagnostics and you can get a consult by telepresence from a distance. So if you look at it, a whole lot more that we could do to enhance both convenience, access, and lower price in the creation of the kind of delivery model with the right benefit design that the consumer could access. The thing I would close, and I'm going to skip some of the pieces with the telemedicine kind of taking off. The thing I would close with is one of the most significant things that is happening is the availability of technology, but no availability of an integrator yet, where we could actually enable the patient to be at the center of their own care. We've got wearable sensors that can actually measure with, FDA approved, where you can measure vitals ongoing. You have digital and mobile interfaces to be able to interact with clinicians. You have cognitive implanted devices on dosing different kinds of drugs that are now in place. With 5G coming online and Wi-Fi largely ubiquitous, you've got very high-speed connectivity between all of these devices and methods that you have. And then with machine learning and AI, so if you were to think about it, where might this go? You just think about a diabetic who today experiences care in a very fragmented way. Very, very fragmented way. And if you think about what they could do in the future, if they've got all of their vitals being measured on an ongoing basis, that's being run through an AI. That AI can easily read and triage what kind of intervention is required. Is this person not keeping up with their nutrition? Is this person, is their blood glucose level fluctuating too much? Have they not taken the insulin? I mean, all of that. It could then alert a set of caregivers, whether it is, hey, you need to go to the ER, and they could, kind of point out to the person they need to go and head that way, or we just need to set up next week an appointment with your primary care physician, and they give an alert to the primary care physician, maybe even make the appointment if they have access to their Google Calendar. That's not that hard to do. All of that can be done today in being able to help this person kind of manage. By the way, if they are older and have a bunch of comorbidities, they could provide access to the rest of their caregivers, family members. Older folks could provide to their kids, kids for kids, parents could have that, and have a real view of having this information. All of that being available to them. And so a very different model of care delivery where we would provide real-time continuous care, but not in the way that we have very highly expensive interventions provided by physicians as the only way to do it on a periodic basis. That's all technology to do that is there. Some amount of it requires government action that Mark talked about. Data today is not available actually for me to have on my iPhone in the way and be able to delegate that easily because it's stuck with a bunch of different providers. And then, private parties, and this is where payers, providers, or other tech companies looking at this, do they become the glue, the creators of the ecosystem that would allow that to come into place? That's when we can really kind of unleash some of the power of consumerism in really getting to better convenience, better access, better outcomes, and lower cost when you put it all together. So let me stop there. There'll be a lot of discussion throughout the set of panels where folks will delve a lot deeper into it. And as Mark said, there's a lot on the policy side, but there's a lot of innovation on the private side waiting to happen as we start thinking about the consumer and as we get beyond what perhaps is maybe the 1.5 innings of a 9 innings game. So thank you very much.
I'd like to quickly introduce Jenny Cordina, who's also a partner at McKinsey and has overseen a lot of their work on what consumers are thinking, what the trends are in consumer activity around in different segments of the healthcare system, and is going to present a summary of some of that work for us right now. Thanks, Jenny.
Hi, everyone. Thanks for giving me a few minutes to share some of our research into the consumer. I've had the privilege of leading our healthcare consumer research for over a decade now, and it's wonderful seeing a room full of folks excited about this topic. I'm going to dive into just a few kind of key points from some of the research that I think are reflective of some of the dialogue that we're going to have today. And we're going to actually start with a quick voice of the customer. So a few videos that highlight a few of the points that you're going to see with actual facts that are going to come later on. So these are just a little snippets. Not able to get it going? All right. All right, well, no video apparently. All right, so we'll just go straight into the data then. All right. So there's kind of key 4 points that we're going to talk about today. The first is this notion of innovation, which is coming through everywhere. The consumers actually want innovation. We're going to give you a little example of where they're looking for innovation to kind of tailor some of the dialogue. The second is how to connect with the consumer. One of the interesting things, and you saw this a little bit in some of the data earlier today already, is they're not necessarily always staying in the same insurance products, in the same type of insurance, nor with the same physicians and caregivers over the course of, within a year, let alone several years. And so how do we engage them in care continuity over that period of time? The third is how do you enable and incent them? That theme has already come up a few times, and we actually do see that consumers are quite interested in engaging in the healthcare systems, sometimes willingly, sometimes not. But the interesting thing is in many cases they are willing to engage in ways that we don't engage them today. And then lastly, and I think we all know this, they really do want to engage digitally. And even as they get older, I think there's a lot of research that we've seen that shows that even the much older consumers in Medicare and the like actually really want to engage in this way, in some cases more than others, just given how involved in the healthcare system they actually are. All right. So the first topic here is on innovation. And in our last research this past summer, we actually just left an open-ended question. And we said, what companies should healthcare companies essentially aspire to be like? So it's a very open-ended question. And what you see here are the top 5 companies that popped up. Now, every year we ask a question somewhat like this, either about, what's the most consumer focused or what's the most innovative. And you actually get, no matter how you ask the question, a very similar set of companies. Now, what I find interesting about this is the first 3, I think most everyone say, I get that, right? Amazon, Google, Apple, these are the namesakes that always come up. What was interesting, though, is Chick-fil-A, obviously. I'm not sure if anyone has kids, but both of our girls love Chick-fil-A quite a bit. I'm seeing some other folks in the room where they exist, but you can see why, right? It's great customer experience. People go in, they get exactly what they're looking for, right? That's kind of the point. Even Walmart, right? People know they're going to get low prices. They can get in and out with what they need. Other companies that come up often with various forms of this question are like Google, Nordstrom's, Target. They have a consistent set of themes, though, right? Where consumers are able to engage in ways that they want. They are able to get what they expect, and they can engage across a number of different mediums, right? And it's a good experience. We can all relate to this. And that's what they want from us, right? This wasn't, anything else other than saying, you healthcare industry, this is what we want you to look like. For those that are representing insurance companies and providers, that also is a bit of a warning, right? They're very open to disruptors coming in and saying, if you can give me a better experience, I might even be open to that. All right, so what do they want us to innovate on? This is actually one of the sort of insights. Again, we left it very open-ended. We asked them, what are your most frustrating experiences that you'd like to be solved? Now, if we'd asked this question in any other industry, we probably would have come up with much more creative answers. But in our industry, consumers came back with 3 predominant things. 1, they want to understand their medical cost. Can you imagine in any other industry somebody saying, I want to know how much something is going to cost me? 2, understanding if their treatment would be covered. And 3, understanding their healthcare bill. So when you just step back from this and you say, what does the consumer expect from innovation? It's actually pretty basic, right? They're looking for simple things that in any other consumer industry would be an obvious thing that they should be able to receive. So while we aspire, of course, to achieve much greater things than what's on this page, starting with the basics would really go a long way with the consumer. All right. So I'm going to shift to the second topic, which was all about how do you connect with consumers over time and the fact that their experiences in healthcare are not always consistent. And so one of the things I want to share with you here is I think most folks assume that the PCP relationship is quite consistent and very, very important. And while I don't think any of us in the room would disagree that the PCP relationship is extremely important, we also see that the PCP relationship is in decline. And so here is a self-assessed, you have a PCP. This will probably look different than data you see where we assign PCPs or allocate PCPs to consumers. These are what consumers believe, whether or not they have a PCP. And as you can see, it's been going down every year. And you might say, well, that might be true overall, but it's certainly not happening with the sicker populations or Medicare populations. Actually, the Medicare population saw the biggest decline, over 6 points of decline, right? They're still very high, but 6 points of decline. We see it across every health group, every age group, every insurance group. PCPs are in decline. There wasn't a single one in which it stayed flat or increased. And that's happening for a number of reasons. The other thing that we found that was quite interesting in this data was when we asked, how loyal are you to your PCP? We actually found that a large majority of consumers do not just see their PCP, but they see many other caregivers when it's more convenient to them. Hence the rise of things like retail clinics, urgent care centers, and the like. So even if they have a PCP, they're not necessarily getting all their care there. And as we talked about with data transferability and things like that, that also means that nobody in the system actually knows what all that care is a consumer is necessarily getting, even out of the basic stuff. Right. So you saw some of this data in terms of the rise of the retail clinics. This data is also very, very consistent across urgent care centers when you say how many people have essentially self-reflected that they are going to retail clinics, and what are they willing to do there? And so what you see on the right-hand side, this is what I actually focus you on, is they're willing to do quite a lot. So we actually asked about 20 different types of services within the retail clinic setting, whether or not they were willing to get care. And there wasn't a single thing that we presented in that 20 that seemed reasonable that got less than 50%. So point being is there's probably a lot more that could be done in these alternative care settings than are even being done today, where consumers are going to be interested in getting that care in the future. All right, if we go to the third topic, this was all around how do you engage and incent consumers? And one of the things that comes up a lot is there's a lot of added cost in the ER. And so one of the things we try to look at is just, again, we have obviously the data from the health system that says, should that person have come into the ER? But what does the consumer think? Did they think that they went to the right site of care for that need? And what was quite interesting to us, as you can see here, is about a quarter of the population in the survey said that they felt that they actually could have gone elsewhere other than the ER for whatever they had gone in for. That's obviously a very large proportion that know that they actually didn't go to the right place of care. Now, what's interesting on the right is we said, well, why did you go to the ER if you didn't need to go to the ER? And the number one thing is the doctor's office wasn't open, right? So this goes back to it wasn't necessarily a life-threatening issue or anything else, but they wanted care immediately, and so they went to what they felt was the best place to get care, in this case, the ER. Obviously, there's other places that could have been directed, such as retail clinic or an urgent care setting or things like that. But it gets back to that notion of how do you actually engage consumers, whether it's telemedicine visits or alternative sites of care, how do you actually help them get to the right place of care? Second is this, I wasn't sure how serious it was. Again, this is a place where you could imagine a televisit could have been a great opportunity to help direct where a person might be able to go. Again, maybe an urgent care center, that sort of thing. So there's actually quite a bit of opportunity here to help engage the consumer about where the right points of care would be for whatever it is that they were dealing with. Right. So this is on that notion of incentives within the product design. So this is all stated and what people said, so take that for what it's worth. But what we wanted to do is we created a set of product designs for consumers, and we said, how interested would you be in this product? And so what you can see is the three tested different incentives. The first was essentially on steps a day. So if people met, with their Fitbit, for example, a number of steps a day, how interested would they be for a reduction in premium? But if they didn't meet it, they would actually have to pay more in premium. The same thing with exercise, and then the same thing with weight measurement. What you can see is in the interested category, we had over half the population of survey respondents say that they were interested in these products. Now, I will say when we dug into this data a bit deeper, we did see that folks that tended to be on the healthier side tended to be more interested in engaging in these programs than folks that tended to be on the less healthy side. So we definitely saw that. Now, when you accounted for that difference, we didn't see as much difference across age ranges. So what was interesting, if you looked, for example, at the Medicare population versus the individually insured population, for example, you didn't see a dramatically different view of this at all. Right. And then the last topic was all around digital and digital engagement. And I think this is a really important slide in that it shows what consumers prefer. So again, this is what they stated. We tested a set of things that went into each of these, or actually quite a few more. But across every element of the consumer journey for their health, we asked them, how would you prefer to get this service, essentially? So everything from I sign up and join all the way to I'm managing my health. And what you can see in that blue is essentially the percentage of consumers that said they'd prefer to do it digitally. And this was a consistent theme across many other elements that we don't actually have on the page, but you can see across all of them how much consumers really prefer to engage digitally. And if I just highlight a couple that really stood out for me. So for example, under the I sign up and join, when we looked at the individually insured population, their number, for example, was dramatically higher on the preferring to do that digitally because they've been trained to do it digitally in the way that they have to buy that insurance. Similarly, if we go to I maintain my health, the Medicare population was actually the highest on this one in terms of wanting to engage digitally. So I think some of the assumptions that we have about necessarily on certain populations about what they will or won't want have an opportunity to really challenge that because consumers more broadly are quite interested in engaging in these ways. And then one last page that I find particularly compelling is one of the big challenges that the industry still has is actually lack of awareness. And so one of the things that we looked at when it came to digital engagement, because I think a lot of folks do struggle with digital engagement still being relatively low. And so we say, why should we invest in this? I get the consumers say they want it, but they're not engaging. Well, part of it is actually familiarity or understanding what's available to them. So what we did here on this page, you can see is we try to essentially correlate for how familiar were people with the solutions, and then what was their likelihood to essentially use them. And what you can see is they're highly related. The more familiar people are with the solutions that exist digitally, the more likely they are to engage with them. So there's a real opportunity to find the right forums, the right partners in their healthcare to essentially engage consumers so that they're aware of the digital options available to them and get the experience using them. Now, I will say, before I close, that we did find that if they had a bad experience once they engaged digitally, they were much more hesitant to engage digitally and those sorts of things in the future. So there is a bit of a let's get it right before we get out there so that they have a good experience and want to keep engaging in that way. Great. Sure. All right, we're going to try to play the video before we wrap up. There we go.
The most challenging experience that I faced with my healthcare company was actually getting the right paperwork sent to my house, and in order to speak to the right people, I was transferred and transferred and transferred, and even after being transferred a million times, whoever I talked to still didn't have the right information. So it's very frustrating to be waiting on the line forever and being transferred a million times only to get on the line with people who have no idea what you're talking about, even though you follow, as the consumer, the right direction.
Yeah, my biggest challenge is simply that I move around a lot, and trying to deal with a primary care physician is just impossible. So I have to have more flexibility and transparency about how and when to use it. Being able to get health services and knowing up front exactly what it would cost, just like ordering dinner.
So I had a really bad relationship with a healthcare in the last 3-4 years. The biggest thing is that even if you do have insurance, it's practically impossible to find a doctor that's accepting new patients. I actually had to deliver a baby with no prenatal care because I did not have a gynecologist. Nobody would take my insurance, and that was that.
So the biggest frustration I have with the healthcare industry right now as it is the fact that you don't know what you're going to be charged. So I call the insurance, they're like, well, we need the CPT code from the hospital. So I call the hospital, get the CPT code, but they can't give it to you because they don't know what's going to be done. So it's like the only thing in America that you go and have a service and you have no clue what you're going to be charged for that, which is ridiculous.
Frustrating. It happened to us recently is my husband had shoulder surgery. While in the hospital, a gentleman showed up in scrubs with a piece of equipment. He said our doctor recommended that he use for rehab. We took it home, hardly used it. When we returned it, we received a huge bill for it, which was not prescribed by a doctor, and we did not know it was not covered and would not have taken it. We felt it was kind of a scam.
Back in January, I had a seizure, and my insurance company at the time refused to cover the overnight stay to try to figure out what the seizure was caused by, because they said that I was able to cure it with lesser treatment.
I would say scheduling has been an issue recently. My primary care next available is a month from now, which is a little strange. And then also I would say just when searching, trying to find a good doctor, sites like ZocDoc are better than it used to be, but it's still, there's just a flood of people that it's really hard to tell who's good and who's not.
Great. Well, hopefully that gives a good insight into the rest of the conversations you're having today. Thank you.
Ginny, thanks, and thanks for the technical help in giving us a good digital experience, even if many of those American consumers are not having that yet. We're starting out our follow-up discussions with Don Rucker, and I'm going to introduce him right now. And the reason we're starting with that is because, as you just heard, data and sharing information is at the root of effective healthcare and effective engagement and support for and integration of to address care needs for consumers. Don is at the center of the administration's very high priority efforts to try to change the kinds of experiences that you saw just there. And he's going to give us some remarks to start off this discussion, and we'll have a chance for some back and forth with you all before Don has to leave us. Don is the National Coordinator for Health IT at the Department of Health and Human Services. That post, especially in the current environment that we were just describing, is very important for the formulation, not just of federal IT strategy and coordinating policies, standards, programs, and investments that relate to IT, but as you heard, a fundamental part of the administration's initiatives on getting to value-based care and addressing some of the gaps in care that those Americans so eloquently described. Don comes from Harvard University and then graduate education at Penn with an MS and an MBA as well from Stanford. He is one of the few emergency medicine physicians I know who also read Schumpeter and a lot of political economy. He most recently he started his career in informatics at DataMedic, where he co-developed the world's first Microsoft Windows-based electronic medical record, and then for over a decade was at Siemens, where he was the chief medical officer before coming into his work for ONC now. So Don, we're very delighted to have you with us today. Thank you.
Well, thanks, Mark. So, that was a fascinating video. Congress actually has heard the exact same complaints. And when you look at the sort of the empowerment of patients, and as Mark pointed out, a large chunk of our healthcare spend is, maybe arguably almost all of it, is either indirectly or directly controlled by federal policy. When you look at that, Congress decided to take, I guess we can call it another whack, that's not a technical term, at fixing this, and that was the 21st Century Cures Act. So that law was passed in December of 2016, almost unanimously. I think 390 votes in the House, over 90 votes in the Senate, signed by President Obama. And we are now in the current administration. President Trump and the White House have been extremely interested in healthcare consumerism. As you all know, that was a staple of his campaign speeches. If you had a chance to listen to any of those, HHS, as was pointed out, Secretary Azar, CMS, so and obviously ONC. We're very interested in taking what's actually in the Cures Act. The Cures Act is a remarkably broad act. So we're talking about Title IV. So there's other stuff in there about the FDA, which probably has had other conferences, I'm sure. But in that, there is a broad call to digital consumer empowerment, really. And it almost goes beyond what was just outlined here, because what you saw here, I think, sort of started with digitizing some of the things we have. But when you read Cures, Congress was actually interested also in new business models and root innovation in this, I think. Maybe I'm imagining too much, but I think that language is in there. And so what are we really talking about? What were the goals here? What are the goals of the administration? It's a very, very patient-focused set of things that we're trying to do. And that, you saw, on the slide decks, just dozens and dozens of things that we could do, right? So trying to focus this down a little bit on the things that are economically empowering for the future, we've sort of come up with 3 use cases. They're much argued about. I'll just give that in passing. But I think the first use case is, what do we need to do to get data onto people's smartphones, right? The paradigm of the clinician has the record in various bits and pieces, putting it together as sort of a Where's Waldo type of activity, that is just not necessary anymore. That is just not where technology is today. So what do we need to do to get the patient's record on the supercomputer in their pocket or their purse? That will, it's not immediate. When you see medical data electronically, it is not a thing of beauty. It's ugly. It's very ugly. So, it's a work in progress. The second big use case is, as Mark pointed out very clearly, most care is actually still provided and purchased by third-party payers, right? That big delta, the land beyond the deductible, I guess we'll call it, McClellan land or something, I don't know. The land beyond the deductible. Would it surprise you today, as you think about that, and this is obviously an extraordinarily educated group about healthcare, how do you actually see what healthcare providers are doing in that space? I just throw that out to you as a thought question. And the reality is, you have very poor ways of understanding what goes on in that entire spend. There is essentially no computable accountability for providers in the U.S. today. So what do we have, right? So what do we do? Well, we have some things that are called quality measures, which are very narrow, and by the time everybody's finished gaming them, essentially impart no further economic information. And their value is putatively analyzed by, let's say a research paper, but the research paper is actually only about, does this population do better if they have this parameter or not? That says nothing about the implementation of the quality measure in the wild, in the real world, when it gets to payers. And, that's, I think, interesting. The only other way electronically to get data is through very one-off measures. Get a script file, we agree, provider A, provider B, whatever, we're the payer, we negotiate with them, and we get some kind of a download over FTP. These custom downloads are expensive to deal with and essentially add to the general lack of accountability and opacity for that. The final use case to think about as we look at cures is the classic one that providers think about. Providers have not gone to this talk, okay? The American providers have not seen that very nice McKinsey video. Their view of the world, urgent care, that's somewhere else, whatever. The bulk of providers are only really, when they think of interoperability or data, it's, can I get the chart from another provider and, make that easier? And that, of course, as it plays out in America, has often typically been, whatever success we've had there has pretty much been limited to the highest priced providers in town, when you think about it, who have big, IT systems and are spending, in some cases, hundreds of millions, if not more, on things. That's a very narrow focus of interoperability. It is not a broad modern computer science, web, cloud, machine learning focus. So what can we do about it? So the Cures Act lays out a couple of provisions here that I think are very interesting. And I'm going to list them in the order of, I think, importance that I think they're going to have. As with all guesses on the future, this is a guess, so, you get what you paid for. All right, sorry about that. So first is just the raw frustration that Congress felt on data hiding, right? So Congress has defined in 21st Century Cures a prohibition against information blocking. It is referred to as information blocking. That prohibition is up to $1 million per, when that occurs by vendors or networks. And the information blocking provisions on the provider side are, enforced through CMS and a variety of things we'll talk about in a second. So item number one, prohibition against information blocking. And we see a fair amount of that in various ways. And of course, it's a slippery slope. When is it, I can't get the computer to do it, versus when is it information blocking? And obviously, as you might intuit, that's a spectrum of things. The second is trying to get the various networks that are out there to talk to each other. So we're talking now about health information exchanges, the regional health information exchanges. We're talking about some of the vendor-supported networks, so Epic's, there are others involved, but Epic is lead in care quality, Cerner, Commonwealth. And as you might imagine, there's a lot of technical details on what these networks do, what these networks could do, whether these networks actually provide you with truly computable data, even very, very basic things like how do you find out who the person is, where the person is, where they got their care. Is that a manual process? Can that be done truly electronically? So there are a lot of issues in that. And the network issue, of course, is also interesting from a public policy point of view, I would put out, because while these networks have been conceptualized as being medical data networks, medical data and all the behavioral health things that we do have a very fuzzy boundary, right? All the substance abuse, the mental illness, group homes, shelters, jails, community centers, psych facilities. There's a vast sea, all the sort of parts of the other parts of HHS besides CMS that are also running pretty much blind to what we are spending on these services. I'm just in the middle of reading an internal report on what HHS is doing on opiates. I mean, the number of programs, all targeted, I think, at many of the same actual human beings. So we might have this network be a broader thing. Leave that for another day. Arguably the most transformative from a computer science point of view is the concept of open application programming interfaces. So API is the term of art there. And that's, I think, the one that can be the biggest disruptor. It has been, open APIs have been extraordinarily powerful in the rest of our lives. I don't need to ask here, how many people in this room have used a map on a smartphone to get somewhere? How many? I don't need to. If somebody doesn't raise their hand, we'll have a medical inquiry afterwards. How many people have used these things for any other part of their life? Banking, airlines, everywhere. We're using what are open APIs to connect data in new ways and truly innovative ways. You see this when Uber hooks up with Google Maps on a ride-sharing service, and what are the routes and stuff like that. So the rest of our life, we're harvesting extraordinary benefits. And healthcare is pointed out by the various folks. We don't have that. What's been missing? Well, one of the things that's been missing are open APIs. And Congress was very clever about this. I would love to have been there for the various lobbyists traipsing through to get the language in. But the provision on open APIs, it's not the open API that's the most important part, because, right, anybody who can do some programming can say, here's a function call and call it an open API, right? It can be a piece of garbage that means absolutely nothing and is utterly unusable. What Congress said was open APIs without special effort. And it's the without special effort that's actually the extraordinary language. That means you have to use standards and standard tools to, when you provide the open APIs as a provider. And in this current world, that really means JSON, FHIR, healthcare interfaces, the modern internet RESTful stack. RESTful is capital R, capital E, capital S, capital T, lowercase FUL. You can Google it, but that's what modern interface technology is really about. It makes things vastly simpler and easier than the prior connection protocols that we've had to use in the last 25, 30, and earlier years. So without special effort is the absolute critical thing. What we're doing with a number of folks, including a number of the large payers through the Da Vinci Project, with HL7, with the FHIR subgroup of HL7, with Ken Mandel at Boston Children's Hospital, is we are, you may have heard Anish Chopra talk about it, we're extending these FHIR standards, which again, historically, and now historically means over the last 2 years, right? So we're not talking George Washington here. We're extending those standards to cover populations. Right now, those are one person at a time standard. You cannot have an accountable learning healthcare system and, or get payer data if every one of those things is a single query, right? You need a broader query just for computational sanity on that. So you may hear this referred to as population level services, bulk data, batch data, flat FHIR. It's all the same thing, but it's using the FHIR and the JSON, these RESTful components, to actually, for the first time ever, have computable standards to look at what we're getting in American healthcare on a population. Amazingly enough, has never been done before. Now, I just want to put a caveat in. All of those transactions, unlike the individual things which are on demand by HIPAA, right? So if you're a provider and I come up to you and with my smartphone, you have to give me the data under current law. And we're putting in the specific policies, a la what Apple, what the Apple screens you showed. The bulk data, the population level data, still is a HIPAA covered entity business associate type of transaction. So there has to be a contract there that nothing changes. We're not changing anything about HIPAA, either for individual access or population level access, but it is a lot easier to do that when you have a standard rather than when you're doing it one-off. It is worth noting that this is the type of data that you actually need if you're going to use any modern computing tool, right? If you want to use machine learning, if you want to use artificial intelligence, sort of similar sets of things, those things go on data. When, we hear from some of the Silicon Valley companies you may have seen up there, don't even bother structuring the data. You're just wasting your time. Just give me the data feed. If you haven't had a chance to look at the paper that Google did earlier in the year with folks from University of Chicago, Stanford, UCSF, they looked at 2 hospitals and got data feeds. They got about 100,000 data elements per patient for 200,000 patients, converted them into sort of FHIR-based resources, and we're better at predicting a priori selected outcomes than any current classic statistical algorithm, just to give you a flavor. Some of this stuff is here now. So all of that, little bit computational. You may have heard at HIMSS or heard about Seema Verma and Jared Kushner's talk. Each of these requirements on the open APIs, on the information blocking, on the frameworks is currently being put into CMS rulemaking. They have a cycle of when they're going to come out, and it will not be just for fee-for-service of Medicare, but you're going to see this over time for Medicare Advantage and Medicaid. So you will see these consumer empowerment policies. You heard about My Healthy Data and Blue Button 2.0. Those are using that, and Apple. They're all using the exact same data standards. JSON, RESTful, FHIR, FHIR standards to get the data out. So we think with that, we're going to have a market economy really think very long and hard about how these things come together. What we saw earlier, I think, is just the start of potential innovation in delivery models and computations. And as the McKinsey folks have pointed out, these things need lots of data. It's like a steam engine, need a lot of coal to get up the hill, right? These engines need data, and I think the Cures Act, what the Trump administration's doing, what we're doing on that, will bring all of us to what we need as consumers, which is a healthcare system that's responsive to our needs, as opposed to sort of having been, as it has been, sort of captured by provider preference over the last 50 years of non-market-based prices. So.
Thanks, Don. All right. Yeah, we have time for a couple of questions. If anyone does have a question, there are microphones in the room, so please head on up. Maybe one, Don, while people, actually, is there already a question, or? Okay, setting up. So while it's setting up, you talked about, and you heard from Shabam talk about and you heard from the consumers in the video talk about how what they'd really like is the information that they particularly need right there, integrated for them, so they can make effective decisions. And I guess one way to get there is the steps that you're taking. But as you say, this is a lot of data that needs to be put together, a lot of open APIs and so forth. Another way of viewing some of the horizontal and vertical consolidation that's going on in the healthcare industry now is sort of taking that internally and having like a big system, including primary care and specialized providers and hospitals and insurance and PBMs and all, bring that in-house and not having to deal with all of these policy issues and complexity. They still have to integrate their own data systems, and then maybe on top of that, having the advantage of being able to negotiate lower prices with whoever's outside their system, I know the drug companies maybe, and not having to deal with all of this complexity. Are you going to keep up with that trend? Do you see this as an alternative to it, where the integration of data that consumers need doesn't necessarily require the integration of the entire healthcare system?
I think open APIs and these standards, so the standards I've outlined, let me give you the caveat, they're very early, right? The population standard is being built. The other standards are extremely early, and we're still largely using a whole different set of older standards that, this will evolve over time. I think it is honestly unpredictable what the combinations are going to be, how much of that efficiency is internal, how much of it is multi-party. My guess is there'll be scads of both. I think that's the way the internet economy and the app economy have played out over the last 15, 20 years. I mean, if you think about it, Windows 95 was the first version of Windows that even had a protocol for communications. It was the first time there was an IP stack in the software. So this is moving very rapidly. Even within policy, it's moving rapidly. Prior ONC work put in portals, which was state-of-the-art, let's say 5 years ago. I think when you look now, it really is more sort of an app economy. So I think these things will be all over the place. The more they are, the more they are. This is a network effect.
Thank you. We've got time for one more. Maybe you could let us know who you are and ask.
I'm Neil Belson with Potomac Law Group, a new model law firm in Washington, D.C., and I focus increasingly on precision medicine and health IT. I don't know if I have time for two unrelated questions, but I'll try and you see. First is, I know you're putting out regulations regarding data blocking and some of the other things you mentioned. But until and in the absence of such regulations and legal constraints, who, if anybody, has an incentive, a market incentive to increase interoperability and data interaction in the current system? Are there any market incentives for anybody to do something about it without your driving it? Second is regarding data blocking specifically, what I come across a lot in precision medicine is genomics companies, bioinformatics companies, pharmaceutical companies have gone through a lot of expenditure to build up their database with individual informed consents of tens of thousands, maybe hundreds of thousands of patients. They often advertise their database of patient information as a company asset, even on their websites. We have 110,000 patients in our database. They don't really want to give that up, and other R&D companies and academic researchers complain, and this is a major limiting factor in precision medicine. They can't get the data, which is regarded as highly proprietary by the pharmaceutical companies. This is not so much the delivery, but the R&D. Is that part of what you're aiming at data blocking, or is that a separate animal entirely
Well,
because it's the R&D?
You know, to the first point, obviously, Congress wouldn't have passed laws if it thought the incentives were really strong, right? I think so. The incentive is the law. I mean, that's sort of brutal, but that's what it is. Now, again, why is that? That reason's pretty simple, because for the last 50 years, the American public have not been the consumers, right, in a true microeconomic sense, right? We are not the buyer of health care other than as outlined. Once consumers get more in control of the purchases, the economic incentives to do this will be vast, right? That's why you have competitive airline pricing, hotel pricing, right? Because markets spring up rapidly on that. The data we're mostly talking about really here is clinical data in the process of care. That's what this is really about. This is not really about other people's sort of provision of data. This is about data that people have already paid for and should be part of their care, and should be part of their care to be portable. They already have legal rights to it, just the legal rights aren't effective under HIPAA. But make that clear.
Great.
Thanks.
Don, thank you very much for joining us. It's clearly a transformational time in terms of access to healthcare data, but a really complex and challenging environment as well. All right, I'd like to ask now, we're going to move into our first panel discussion. I'd like to ask our panelists to come on up. If you look at the clock while they're coming up, we're running a little bit behind on schedule. We're going to make up some of that time, and I'm not too worried about it. But we did want to turn now to what's going on outside the U.S. And if you look at your agenda, you see that there were 3 panelists originally scheduled to be with us. Unfortunately, Penny Dash had a family emergency and so is not going to be able to join. That said, I think we've still got a lot of perspectives on international activities thanks to the 2 panelists who are with me up here right now. Krishna Udayakumar is the founding director of the Duke Global Health Innovation Center, based at Duke University, but with a global reach, focusing on generating evidence and support for the study and adaptation of health innovations and policy reforms globally. He is also the head of a number of related activities, including the executive director of Innovations in Healthcare, which is a nonprofit co-founded by Duke, McKinsey, and the World Economic Forum, which curates different innovative solutions around the world. He's also associate professor of global health and medicine at Duke, associate professor at Duke NUS Medical School in Singapore. He's very familiar with Singapore health reforms, and a core faculty collaborator on our work at the Duke Margolis Center for Health Policy. And then next to Krishna is Dante Mora, who's the chief of staff at Trillium Health Partners. Dr. Mora has been the chief of staff there, where I think his job is really about transformation in one of Canada's largest academically affiliated hospitals, serving Mississauga and some of the surrounding communities. He's been working and is known globally for hospital process improvement, care innovation, and more efficient, high-value allocation of resources, with a lot of recognition for that, including the 3M National Quality Award and the Goldie Award for Leadership. He's also on the faculty at the University of Toronto and their Rotman School of Management. So Krishna, Dante, great to have both of you with us today. Now, so far in the discussion, we've really focused on the U.S. context, but as you all know better than most, the challenges that we're talking about here are challenges that are being faced around the world. Now, the institutional context, the regulatory context, the coverage context is a bit different, but the opportunities for improving quality and safety of care, the opportunities for engaging people more in making effective choices, contributing, some people call it co-production in healthcare services, are just as broad outside the U.S. and maybe in some ways easier to pursue. And I wonder if you could each start with a few introductory comments based on what you've heard so far about what you see about the opportunities to learn from and maybe some of the differences in experiences outside the U.S. in engaging consumers much more effectively in their care.
Well, thank you, and very excited to be here. I'm going to start off by just talking a little bit about the Canadian system. Just Don Rucker, sort of when we just introduced ourselves, he said, "So you guys in Canada, do you think you guys have it cracked, or you got it all set up?" And I did, and we certainly don't. And a lot of the challenges that were described actually translate. Yet there's some slight differences, and so I'll maybe comment a little bit about that. You know, at the bottom line is the Canadian system is a provider-based system as well, right? So the consumer hasn't had that power within the system, and that's very, very similar. The size of the health insurance markets are about the same. So we're about 75% health insurance, and similar in the U.S. It's just we have a single payer that provides 70% of it. But so the insurance structures are somewhat different, and where we've had advantage when you're looking at a health system. Really, what you're doing is you're balancing quality, access, and sustainability. And so our single payer system has been able to manage some of the sustainability side of things, and we spend about 11% of GDP on healthcare compared to the American 18%. But what we're trading off right now, there's a couple forces that are very powerful in this space. Is we are trading off on access, and that's actually where we're seeing a lot of consumer power and changes within the marketplace. So whether you're looking at certain provinces like New Brunswick, where the median time to seeing a specialist and getting treatment is almost a year, or where you're looking at hip replacement surgery taking about 18 months from referral to treatment, there's access issues. And then that extends into primary care, where people are unable to get visits in a timely fashion. So what I would say in the Canadian marketplace is there's not a lot of spare capacity around. The market has been managed by not releasing supply into the marketplace, whether that's new drugs or OR time or providers. But that's created a powerful access issue that is not for episodic or catastrophic care, but for access to primary care and to other specialists. That is creating a market there that is very interesting. And I'll provide some more I'll provide examples of that as we get into the panel. But I think it's really important to see that that's part of the pressure. The second thing that we're seeing is there's no doubt that once you activate people and they get their data, they behave differently. And so in the Canadian model, it was almost sacrilegious to think that a consumer would pay. Like it would never happen. But once people start getting their data and they start wearing wearables and they start collecting their health data, they behave differently. And about a third of Canadians are tracking their own health data, which is quite interesting. Most of them are healthier and younger, so you're not into the chronic disease side, but that's actually a big number. And so people start to behave differently, and we're seeing a variety of companies on telehealth that are pan-Canadian, that are providing teleconsults, and where Canadians are paying for access to those services, even though they have plans that would pay for them, but they're paying for them to have preferential access. And the Canadian Health Act allows for space for innovation in that place, which is very interesting. And then finally, what you're seeing is consumer power with genetics. So where people particularly with mental health, there's been a lot of press around this, where as you get genetic testing or and they have that information, using that information into the healthcare system around choice, and that's how I'm providing very interesting pressure from a policy perspective and regulation perspective. And I want to talk a little bit about that later on, about where consumer choice isn't just about the supply side and having new companies and new services formed, but also where consumers actually start to advocate, and you have changes in regulation or delivery systems and that can be as far-reaching of thinking about medically assisted dying, which is a huge thing that's happened in the U.S. in changing policy, right down to access to your health record. So I'll stop there, and then I look forward to the conversation.
Thanks, Dante.
Great, thanks for the opportunity to be here. What I was reflecting on and hearing the voices so far today, seeing some of the videos, is how much of the struggle is really around things that are quite incremental and starting point, is how much we struggle around things like, what is the bill and how can I understand it? And the work that we do cuts across low, middle, high-income countries around the world. We're looking for the cutting edge of what organizations and individuals are doing from the innovation perspective. And a lot of what we see is really moving beyond this incremental to really think about redesigning or rethinking of what health systems would actually be if they were centered around consumers. So instead of making it a little bit easier to understand a bill after the fact, what if we actually co-developed our systems and our services with our consumers or communities? And we see that happening. There's a formal mechanism called experience-based co-design that is now active in several countries, including the UK and Australia. And there's a whole foundation called the Point of Care Foundation that has developed a toolkit around how to do experience-based co-design. So why don't we actually design our systems around what our consumers want? This concept of price transparency comes up quite a bit as something that we tend to struggle with. And that tends to be very different in different parts of the world. So parts where there have always been market forces that have driven the health sector, take a place like India, where 70% of healthcare spending is still out of pocket. There are many negatives that come with a lack of financial security and a lack of systems and risk pooling. But what that also leads to is inherent consumerism, because people are making decisions every day based on paying for perceived value. And so one of the most shocking things when we take people from the US or Europe to see some of these innovations in India is you walk into a hospital and what you see in the lobby is a price list. You can decide how much, what you're paying for what procedure or what care that you're going to access. And some of that is really trying to be consumer friendly to help understand if you're going to make choices, you need information. And some of the price transparency is now coupled to things like bundled payments for services that are not driven by third-party payers or government requirements, but are seen as actually a part of being consumer friendly. So if you're going to go in and get a surgery and have rehab and recovery along with it, having a bundled and predictable price removes the financial risk or transfers that risk to the provider. And in fact, providers are using shifts in risk like that to actually drive quality, because unless you create quality the first time, the financial risk of treating complications falls on the provider, not the patient. So we see very different models, whether that's happening in low to middle income countries where there are market forces in play, or where there are largely publicly driven systems of care, because they're, I think, trying to get to the point where the systems they're creating and the systems they're refining really are built around the needs of consumers. And I think that's a very different type of conversation than oftentimes where are we today and what's the next incremental step we could take.
Right. Well, I'd like to follow up on your opening comments at two levels. One is maybe some more insights that each of you could provide. And Dante, you mentioned you had a few that you'd like to talk about, and Christian, I know from your work there are a number. Some examples of these kinds of consumer empowering solutions that you are seeing that you think are particularly promising elsewhere, but also potentially here. And then I want to come back to this issue that you all have raised, that Don and others earlier today have talked about in terms of how do you make those kinds of reforms work in a country like the U.S., where there is a lot of payments that come through third parties? They're not necessarily designed in a way that is consumer-centric. And Dante, you mentioned some of the same issues in Canada. But first, I'd like to hear a little bit more about examples. Maybe Dante, to go to you first, you mentioned that innovations around telehealth and around other areas where there's been access pressures, in particular in Canada, that have facilitated these changes in areas where maybe there's not so much traditional government regulation restricting access. But maybe you could talk about a couple of examples that you'd like to highlight. Christian, I know you've got many as well, but let's turn to those.
So I'll try and do this in an organized way and go from like far out and in. So like I think one example, like, and I mentioned it, is medically assisted dying, and that's something that's recently now happening in Canada, and that was a consumer-based. This is something that our population wanted. It had tremendous pressure in our system, and now our whole system has reorganized around this. There's a whole legal construct and delivery structure that's been put in, but that, from a consumer voice side, that's a very far realm of it. Now I'll go to the other side and talk maybe about just from an access point of view. There's a whole bunch of companies that have sprouted in the Canadian marketplace, Akira, Maple, other companies where just to get an appointment, your primary care appointment is covered, but it's hard to get an appointment and it's inconvenient. So what these are telehealth providers that allow you to video conference pan-Canadian or wherever you are in the world, and consumers pay for them. And initially they sprouted up and consumers started paying for them, and now private health plans are starting to pay for them as well. And then what we're seeing now is that created a competitive pressure in the system, so that now some of the public telehealth, like the Ontario Telehealth Network, is now, and I'm not saying this is the only reason why this is happening, but now you can do e-consults for people at home. That's actually quite transformational in having consumers start to move the market from first being able to get their prescriptions refilled or mental health, and the pricing is very clear. The consumer pays for it, and it's starting to change the market. Another area where we're seeing sort of market changes is there's a company called Dot Health. And what they did is that they started off that consumers, women who are having babies, wanted to see their ultrasounds, and it was difficult to get it. So they started there. And now they're moving into sort of triangulation of getting your health records, and the consumers are paying for that. And they're doing an interesting piece of work in London, Ontario. It's just southwest of Toronto, about 300,000 people, where what they're doing for the consumer is getting their records from all their hospital systems and from the pharmacies and from their primary care doctors, and actually allowing the consumer is paying for that, which then activates them, and they behave in a very different way. And you know what? Just an example of once providers have information, or once consumers have information, it is very powerful. So when, as a physician or like our mental health staff, when somebody comes in and says, I'm not going to go on that medication, or I'm not going to put my child on that medication because they actually aren't going to respond to it. It's very powerful. It changes the way the system works. And just as talking to an Emerge doctor on Friday, and he said, I had this incredibly interesting experience where I had a patient in the Emerge, and I said, I'm going to go check check your ultrasound. They said, no, don't worry, I already got it. I already checked on the portal, and it's already done. I can go. That's actually, the power relationship completely changes over, and so the consumers are starting to fund it. I'll give one more example that's quite out there, and then I'll stop. We spent in Canada, and I suspect you guys have done this as well, large databases, hundreds of millions of dollars trying to get public health data on vaccination. And we've, big IBM and other, I should be careful because I'm on, I don't even know if it was IBM, so scratch that. But big projects where we spent lots of money to try and create databases. And they didn't work because they were all created from a provider perspective. And then a guy by the name of Kuman and Wilson, who's a policy researcher in a park, speaking to a mother about how to get access out to her vaccinations, created Cam Immunize, which is an immunization app that now has been downloaded hundreds and hundreds of thousands of times, and now is actually they're designing the back end of the public health system for this app that was created by a mother in a park. And so those are some examples where the consumers have wielded power, whether it's on accessibility or even design of a system, that are powerfully starting to change the system from a policy perspective around regulation to the delivery of the system, to even the design of our public health system in the back end.
Thank you. Some really interesting examples. Krishna?
Yeah, that's great. And I think what's fascinating here, the examples I think are going to sound quite different, but I think build on many of the same principles of how you engage consumers, empower them, give them the right tools to make better decisions, and a lot of it centered on this idea of creating value. So I'll give you a few examples that I think cut across the spectrum of what we see as the leading edge of consumerism being put into practice. And many of them are quite simple. There's a company that's based in the US but working in India that's called Neura Health, that spun out of some student work that happened in Stanford. And when these students went to examine what was happening in a healthcare environment, what they saw was people recovering from open heart surgery that had family members around them who didn't have any idea how to take care of them but wanted to. And so what they created was a training program that is for family members of patients who come in for particular procedures. And it's a train the trainers model. So Neura comes in, trains nurses, and the nurses in turn train the families. So as a patient is recovering from open heart surgery for 5 to 7 days in the hospital, their family members get trained on what to watch for in terms of complications, managing the chronic diseases that are inherent in that patient population, medical or medication management. And they, at the end of this, actually get a certificate. So there's something at the end of this. The family members get a certificate that they've been trained, and what they've shown now is it reduces complication rates, it improves patient satisfaction as well as family satisfaction with the care that they've received. So very simple to do, almost no incremental cost, and shows significant outcomes very early. That's certainly something that there's no restriction to be able to do in a U.S. context, and I think leverages the type of resources that are available. It's staying in this sort of more patient empowerment component. We know that mental health is a particular challenge, especially in trying to engage individuals with mental illness. And there's an organization called Basic Needs that's been active now in 12 countries in Asia and Africa. And we spent about 1.5 years working with them to adapt this model to the US. And it's really built on identifying and empowering patients with mental illness through self-help organizations. It's creating vocational training, reintegrating them into society, and it's better leveraging community-based mental health services. Again, key principles that are applicable almost in any context, and that's now gone into a demonstration project in the US in Detroit. So we're trying to show how these principles can be applied across multiple countries. And then one other thing that we're seeing in terms of consumerism is really the ability to leverage other sectors. I'll give you a couple of examples. One is on the finance side. So there's an organization called Pro Mujer that works across Latin America. And they're a microcredit organization. And so what they are doing is not just empowering women through microcredit, but also creating social networks as a mechanism to empower them in health-seeking behavior and empower them as consumers in the way that they interact with the health system. And the other we're seeing in parts of East Africa. So in Kenya, where more than 80% of the adult population has something called M-Pesa, which is mobile banking. Or mobile money as opposed to using banking. And now you can overlay the ability to create things like health wallets. So you can preferentially put money in people's mobile money accounts that they can use in ways that they are empowered as consumers to make better choices, like getting care at higher quality clinics or those that follow evidence-based protocols. And the other is from the telecommunications industry. You're going to hear in a few minutes from from Abner about the work that he's doing in the U.S. But part of what inspired that is work that Medical Home is doing in Mexico, working with the leading telecommunications firm in creating telehealth solutions that really aren't built on health systems and so can use very different business models to be successful. Or what we're seeing in parts of places like Tanzania and Kenya, where micro-insurance products are being sold as part of a loyalty credit for retaining cell phone services. And so there are many ways to think about the ways that consumers actually engage with industry, with providers, outside of traditional provider relationships.
Lots of interesting examples, and I think you all could go on. For those who aren't familiar with Innovations in Health and some of the work that it does, I refer you to the website. And I know Dante's published a lot on and written and talked a lot about some of the innovations in Canada. I would like to open this up to questions and comments from the audience. Play stump our international experts about your favorite area of more consumer engagement. So if you do have any questions or comments, please be thinking of those now. I would like to talk a little bit, though, about how the innovations you're describing interact with the established healthcare systems and regulations and policies and how those could potentially evolve together. Dante, you emphasized that a lot of the initiatives that you started or that you've seen develop in the private sector that are really consumer facing started outside of the existing public structures where, because of either access restrictions or inability to put the data together, there was room for maybe more room for that kind of innovation. And Krishna, you gave some examples from India and other less developed countries where the public financing or insurance financing generally for healthcare just isn't there to the extent it is in the U.S. I think here in the U.S., people would like to see these kinds of applications, but they probably don't want to go to a system where, they've got to depend on just their own savings, at least for most people in the short term, for major procedures or for managing a chronic condition. Can you talk a little bit about how these might be aligned? We had some discussion earlier about changes in payment that are taking places here that are intended to encourage and support providers more in integrating care and taking more of a population or a patient level focus rather than a specific service focus. Any particular regulatory or financing barriers that you'd highlight as ways that could expand the opportunities for these reforms in the U.S. and maybe other countries?
So there was a slide that one of the McKinsey folks put up that I thought really nicely described sort of those 8 interactions with the healthcare system, from public health to catastrophic and chronic catastrophic. And I think what you want is a rational model to attack different parts of that. So if you don't want the consumer to go after a car crash in a trauma center, that's the wrong space. And we've seen this in disruption of healthcare before. So if you look at like cathing cardiology as an example, it starts in a place where nobody wants and then starts to move into the system. I think that's what you're going to see within the market. Is you're going to see on the wellness side and even going to productivity, a priming and an engagement that then moves downstream from retail. And I actually really enjoyed that the animation of the blocks of services that start to move into the retail market. And if you can get your public plans or payers, like a single payer or a rational plan, to focus on the catastrophic side and where the consumer actually doesn't have power and you don't want them playing and you don't blur it, I think that's the secret. As you start to think about how it can be done and how it can be rolled out. We do, there are examples that we have where consumers got very frustrated with home care, and the handoffs between the system and advocacy created bundled payments where we just did a fairly significant piece of work with 1,500 cardiac surgeries where we had to innovate not only on the payment side but on the provider side with technology and the processes. And we're able to see significant improvement in quality and significant improvement in access and a significant reduction in the cost, all at the same time by using the consumer as the customer and having the plans pay different. And I think that's that's why I've gotten to this point of where advocacy can actually change the delivery systems as well. It's not just about out of pocket. It's about what they're demanding from the public payer and also from their insurers. In the same way that they're now starting to demand those private insurers pay for genetic testing. And once you have your genetic information and your health records on your phone and you can start to choose, it's a completely different game. You tell us what, I'm saying me as a provider, you tell me what to do. Because I don't know. I want to put you on Plavix, but you don't respond to it. You contain that information, and I think that's incredibly powerful.
Yeah, I agree with those general comments. I'd add a couple. I think part of what's lacking is this idea of an integrator function. And I think we see this in almost any health system. It was talked about earlier today. But in fragmented systems, it's very unlikely that the same forces that created the fragmentation are the ones that are going to fix it. So adding lean layers, whether those are management functions, as we see in different ways, or data systems that are not traditional in a U.S. context, electronic health records, but are much leaner data systems that enable the sharing of limited data sets that are the most important for actionable decision making, but mechanisms that actually serve as integrators across many different functions of a health system. I think the other key thing is we've got to move beyond simple financial incentives and thinking that really moves the needle beyond a short-term gain. That I don't think it's all about give the consumer $10 if they do the right thing this year. It's got to be much broader about creating mechanisms to move toward population health, allowing organizations the freedom to design services that are consumer oriented. So I think we've got to create the flexibility and the time and space to say we're going to move toward actually measuring outcomes at a population level, but we have to give provider networks the freedom then to develop or co-develop services that will be appropriate for meeting those goals over time. So at the end of the day, I think unless you're aligning the policy environment, including things like scope of practice and the availability of technologies, as well as the payment systems, giving healthcare organizations the right competencies, because they don't have them right now to engage in these models. Only when you have all of those can you really put the right innovations in place, whether it's a new technology or a totally new financing system, and make it work.
Thanks, Krishnan. And would like to see if there are any questions or comments from those of you here. We have a few minutes left, if there are any for this session. All right, well, you all have done a great job of teeing up what might be possible based on examples around the world. We're going to build on that in our remaining two sessions this afternoon. The first one on making consumerism work, looking more closely at what is working and what's not and how to overcome those challenges within the U.S. system. And then a session focusing on value-based insurance design, the next generation of coverage products to help empower consumers and shift this focus from fragmentation and providers to integration around the services that consumers want and need. But right now, I'd like to thank this panel for their contributions this afternoon. Thank you all very much. Now, we're going to take a short break. So we're certainly running a little bit behind, but we're getting closer. So this will be a stretch break. We'd like to restart again in less than 10 minutes with our next panel. Thank you all very much. Appreciate your tuning in for the webcast, and if you do have questions or comments about our work in this area, please let us know. We would very much like to hear from you. And the webcast information, along with information from the presentations, will also be available after the meeting through our respective websites at Duke Margolis and McKinsey. Right now, though, we want to turn from the very promising, interesting international applications around innovation that we heard about on the last panel to some of the real practical challenges and issues building on our earlier presentation of making consumerism work here in the United States. So this is a panel that includes some real expertise, academic implementation and otherwise on enabling consumer choice and accountability. I'm just going to briefly introduce our David, our moderator, and then the panel, unless you want to do that.
I'll do that. Yeah,
Okay,
sure.
you'll do that.
Yeah.
Okay, so then I'm just going to briefly introduce David Knott, who's senior partner at McKinsey's healthcare practice and leads the firm's Center for U.S. Health System Reform. I've had the privilege of working with David over the years. He does a lot of work on strategy development and actually turning strategies with healthcare organizations into practical transformation programs that span the space of care delivery reform, payment redesign, the supporting administrative steps that need to happen to enable those, along with a vision and practical capacity building focus to make it work. He's long been passionate about quality, affordability, value in healthcare, and has turned that emphasis as well to the McKinsey new emphasis or expanded emphasis around its Medicaid practice. So David, great person to moderate the panel. I'll turn it over to you.
Thank you. Thanks very much, Mark, and welcome everybody. It's great to see everybody still here. You had your big stretch. Hopefully you're caffeinated and raring to go. I'm really excited about this panel. So this is actually making consumerism work in healthcare. And one of the things that McKinsey's doing is trying to do our best to make sure that we're accessing, hiring, exciting, retaining the world's absolute best talent. And as a result, we're really trying to advance diversity and inclusion in our own workforce and in all the work that we do. And so one of the things that I've done as a way of trying to advance that is take what we call the panel pledge. And so I no longer participate on any panels that are not diverse and inclusive. And it's because we want to access the world's best talent that we want to make sure that we've got diverse and inclusive panels. And so I'm here as your token white guy with gray hair who speaks one language badly. But apart from me, you've got a fabulous panel. And so just to introduce them, so just to my left, Abner Mason. So Abner's the founder and CEO of Consejo Sano. Okay, that's all the Spanish I've got. So this is going to be very interesting, just hearing a little bit from his experiences around accessing and enabling, helping navigate for diverse populations, multicultural populations. Next to Abner is Jean Rush, and she's EVP of Government Markets for Highmark, which is now half of that company. So market leader, Blue Cross Blue Shield in Pennsylvania, $7 billion business unit that she now leads. And so Jean will have a lot of interesting things to say around our government-sponsored markets. So Medicaid, Medicare Advantage, the individual exchanges. So what's the same, what's different as you think about consumerism and how you activate that across those markets. And then at the far end, Charlene Wong. And Charlene is assistant professor at Duke University. Adolescent medicine is her background and training. She's also done a lot of work around behavioral economics and how do you actually get sustainable consumer behavior modification, effective decision-making in healthcare. So I'm really excited here because we've got diversity in all its flavors. We've got gender diversity, linguistic diversity, we've got academic, we've got government markets, and we've got entrenched, established competitors as well as new entrants. And so what I thought I'd do is maybe just turn it over to each of them just for an opening soliloquy. So they have sort of 3 or 5 minutes to just make sure they can hit you with the most important things that they wanted to pass on today. And then I thought I'd fire up a few questions, and then hopefully you guys can start to get your own creative juices flowing, and then we'll turn to Q&A from the audience. Abner, do you want to start us off?
Sure. So thank you very much for the invitation to be here. Consejo Sano is a patient navigation, patient engagement company. We are an early stage company, so we are a new entrant. We're about 3 years old. And we're trying to solve for a particular challenge in the US now. And the challenge is basically this, that America has changed. It really has. Over the last 20, 30 years, our country has changed. It's become much more multicultural. So while America has changed, our healthcare system just hasn't. It has not kept up. According to the U.S. Census, the U.S. is on the way to becoming a majority-minority country by 2050. That's not that far away, and I would bet money we'll get there sooner. California, the state where we're located, the company's located, we're already a majority minority state. California is 40% Hispanic. When you add Asians and other minorities, it's a majority minority state. Texas is also now a majority minority state. This is the America that is and is becoming. And it's frustrating for some people, it's frightening for some people. Some people are trying to build walls and all sorts of other things. The truth is, it's not gonna stop. This is the country that we are. And our healthcare system, if we care about it delivering results, it's simply gonna have to change. It's gonna have to change to meet people where they are, because as we become more multicultural, what we're finding, our company, we're about patient engagement, patient navigation. How do you connect with people? You can't have a one-size-fits-all policy. It just won't work. And you can't, I would say, cheap out, but maybe a better way to put it is to take a shortcut and to think that you can just look at multicultural populations, do a Google Translate of your content and your outreach and your efforts to communicate with them, hit Google Translate and say, I've done it. I've checked that box and we've done it. For two reasons. First, it's really not about language as much as it is about culture. If you're really trying to change behavior and to connect with people where they are, we need to understand their cultures. And language is an element of that, but actually it starts with culture, and checking the box doesn't work. And here's the other thing that's really important. These are populations that are accustomed to being treated as not equal or being treated as second-class citizens. They have antenna that is finely tuned to being treated like they're not equal or to being treated as an afterthought. And this may sound surprising, but it's actually better not to try than to try in a way that's insulting. So I know we're going to talk about a lot of things. What we're trying to do is, and we're learning, we're early stage, we don't have all the answers. We put together an incredible team, and we are finding that we are delivering results for our clients. We work with Medicaid managed care plans, with Medicare Advantage plans, and with providers doing Medicaid managed care. And we're doing something really pretty simple. We're just saying to people, to patients, to members, you don't have to change in order to get good health care. In terms of who you are and your culture and your beliefs, you don't have to change. We will change the way we communicate with you. You're gonna have to make changes in lifestyle and other kinds of issues, what you eat, but we'll work with you on that journey. But you don't have to become a different person and pretend you're someone else in order to interact, to engage with the health system. If we connect with people where they are, respect who they are, and just have, in all our interactions, really make the word respect mean something, I think we can get incredible results, and we can drive incredible behavior change and build trusted relationships. We're trying to do it. We're early, but I think we are moving in the right direction, and we've got our focus on, I think we're focused in the right way.
Thank you. Gene, I know government markets has been your life's work.
Yes.
So Highmark, Centene, Cigna. Any observations or kind of lessons learned that you've picked up as you've sort of had the arc throughout your career?
Yeah, sure. Well, thank you. And it's great to be here with all of you today. I thought what I would do is just share some actual examples of things that we have done in each of the markets that David referenced, the Medicare market, the Medicaid market, and then the individual ACA market. Because while there are similarities amongst those different populations, there are also some very distinct differences as well. So I'll start with Medicare in an area that is probably familiar to most people here, and that's the CMS STARS quality program, something that all the payers have been grappling with over the past several years to figure out how do we engage our customers to close gaps in care, to make sure that they're taking the right action so that we are assured that they're getting the right care, whether that's annual wellness visits, it might be making sure that they adhere to their medication, it may be making sure that they test their blood pressure or their blood sugar. And so like many payers, what we have done is to introduce a series of incentives that we call our Passport program that incentivizes the member to take these various steps. But what I think is most critical is not necessarily just the incentive itself, but the fact that it's part of an integrated program. So first of all, we segment the population so that we're only asking people to fill gaps in care that are applicable and important to them. In addition to that, we align with the physician. So it's a dual approach, a parallel approach, where we are communicating and incentivizing both the member and the physician to get that appropriate care for the member. And to give you just one example of where we've seen the needle move, in a 2-year period, we were able to increase the number of annual wellness visits from less than 24% to over 40%. So clearly not where we want to be. There's still room for improvement, but a pretty big growth in just a 2-year time period. Shifting over to the Medicaid world, one of the biggest challenges there is how to engage the members, how to get them interested in managing their health. And so one of the most effective tools that I've seen in that environment is actually something called patient activation measure, which enables us through a series of questions to assess the member's readiness to engage. And it measures them on a scale from 1 to 4, with 1 being not interested in engaging, my health is my doctor's problem, not mine, all the way over to level 4, which is probably most of the people in this room, which is somebody who says, you know what, I manage my health, and I'll consult the appropriate resources, including a doctor, as I need them in the process. And then you have everything in between. But the real beauty of this process is not necessarily just placing the members in a particular cohort, it's what you do after that. And that is to use very targeted messaging to meet the member where they are, but then to move them across the spectrum so that over time they develop a greater awareness of how their behaviors affect their health, and they start to take on more accountability and ownership for moving their health outcomes into a positive place. The third example that I'll give you incorporates a little bit of the digital age that we talked about a few minutes ago, and it's for the individual ACA population. One of the things that we discovered about our ACA members when they first came on board is that many of them had been outside of the healthcare system for many years. They didn't know how to engage, and it was little things like, why is a PCP important? How do I find a PCP? Why is paying my bill on time important? So very practical things that we needed to address. And so one of the things that we did relative to the PCP is we introduced a digital application that's called Meet Doctor Match. And it operates just like an online dating service. The consumer fills out a questionnaire where they're identifying what their preferences are from their doctor. Do I care more about the doctor's bedside manner, or do I care about their technical expertise? Do I want the doctor to engage me in the decision-making process, or do I want them to tell me what I need to do? So there's a whole list of questions that the individual consumer fills out. And then behind the scenes, we have each of our docs fill out a similar questionnaire. And then inside the black box, there's a matching of the consumer to the right physician. And you get a list of physicians that match your qualifications. The idea here being that if you end up getting matched with a PCP that meets your needs, you're far more likely to utilize their services on an ongoing basis. And while we haven't gotten far enough along in this process to scientifically test the results, I will tell you that I took the survey and went to the doctor, and the doctor showed me my x-rays, he laid out all the options, he talked about the decision-making process and how I was going to be making the decision. So I have to say, he had me nailed. So those are just a few examples of how we're trying within the payer space to introduce consumerism and to build accountability on the part of our members in each of our product segments.
Shalene, I know that you've done a lot of research across different markets, including exchanges. Anything from your perch in academia and the research that you've done?
Yeah, thanks so much for the opportunity to speak today. So as David mentioned, I'm a primary care pediatrician and also a health services, health policy researcher. And in my research, I've really tried to take the consumer perspective in most of the research projects I conduct. So I thought what I'd do is just give you guys an overview of 3 different topic areas where I've done some research, and then also 3 sort of takeaways that cross-cut all of those research projects, and would be happy to discuss any of them further if people are interested. So the first area, which Mark alluded to in his opening comments, are incentive programs within Medicaid. I serve a predominantly Medicaid and CHIP-insured population, so it's of particular interest to me. And what we've done in this project is we've interviewed over 70 stakeholders from across the country about incentive programs that already exist within Medicaid, and we've identified over 100 programs. We have had a particular focus on beneficiary engagement because we know that's been a key challenge. Just as an example, in one of the programs that we interviewed a leader in, they had $12.5 million of incentives that were earned, but only 1.2 million of them were redeemed because there's just a lot of confusion on the side of the beneficiaries. And these range from, as you guys probably know, gift cards for well child checks to reduce cost sharing for things like smoking cessation. So that's one area. The second area is thinking about price transparency. And there I've done work looking at, also Mark showed some slides of the state-based price transparency websites, but also recently with a mentee, we went shopping on Google and Bing, trying to find healthcare prices for very common, sort of very shoppable services, as was discussed earlier. The bottom line there is things are quite opaque in all of those different settings. And just as an example, when we looked at over 1,700 websites, only about a third actually had any sort of price available. And even when you did find a price, it was hard to tell what the quality of those prices were. In part, you could see that with the variability of pricing. For example, hip replacement, we found estimates from $27,000 to $80,000. Very unclear, is that an out-of-pocket cost? Is that a charge? Is that a reimbursed price? And then the third area is the choice architecture on the health insurance exchanges. This is work that I've been doing since the very first open enrollment period, and we've been surveying both the public exchanges, so healthcare.gov, as well as all the state-based marketplaces, and more recently we've added exchanges that are run by private companies like Go Health and Stride Health, looking at things like the tools that are made available on these exchanges, for example, the out-of-pocket cost estimators, the provider network tools. Earlier people were talking about network size. We've tracked, is it even visible to consumers when they're looking at different options, what that network breadth is? The answer is in most cases no. To also including the order in which plans are displayed, which we know has a great influence on the way people make their choice. So those are just 3 areas in Medicaid: incentives, price transparency, and the exchanges. And then I think a couple of the themes that I just wanted to highlight, there are 3 of them. The first is that it's more complicated than you think. I think the move towards consumerism is great, and that's certainly why I'm doing the work that I'm doing. But as we have walked hand in hand with consumers, and when I say that, we actually watched people as they were shopping on healthcare.gov and had them think aloud as they were trying to figure out what to do. It's really become very clear to us that it's more complicated than you think. So just in the incentive space, for example, we've been trying to identify best practices, as David mentioned, and a couple of those are, number 1, keep it simple. Number 2, I think as Mark alluded to earlier, and it sounds like you guys are doing at Highmark, really trying to align and leverage existing infrastructure, because what we're hearing from both the MCOs and the states that are running these programs, the challenges that they're having to actually stand these programs up are very substantial. And so if you can build on, for example, the DPP, which is already being incentivized for providers who are already tracking the right data, and then you can layer beneficiary incentives on top of that so that they are also engaged in going to those visits and improving their health. Those are just a few of the example best practices we've identified. We've seen the same sort of thing in the price transparency space. In one of our projects, we actually secret shopped as a parent with a child who needed a tonsillectomy. And we actually called the premier children's hospital, so all the major freestanding children's hospitals, trying to ask very simple question. Again, this is a very shoppable sort of procedure. How much is it going to cost me? And I would say the majority of the hospitals were not able to give us a price, and we were transferred from one department to the next, very similar to the video we heard earlier. A best practice that we saw in this project was that there were a couple, I think there were 8 children's hospitals in the country that had, when we did our study, they had created a specific phone number. They advertised it on their webpage to say, if you want to know how much you're going to pay, because, and I was at CHOP at the time, the Children's Hospital of Philadelphia, the hospitals were getting more and more of these calls, and they realized they needed to come up with a solution. So these hospitals that created these specific phone lines, when we secret shopped them, very immediate, they knew, and they were actually explaining to us some of the terminology and such. The second theme is that basic health care and health insurance literacy is really key to making any of this work in the first place. An example I wanted to point out here is when we were watching these people shop on healthcare.gov, they didn't know what a deductible was. And so if you don't know what that is, making any sort of informed choice is going to be really hard. We actually had one participant in that study who thought a deductible was the amount that you subtract from what you need to pay, which is not illogical because it's called deductible. They're looking at these $6,000 deductible plan options. And then finally, more choice isn't necessarily better. And this is something we also saw on the exchanges, and we were looking at these price transparency websites. You're just looking at lists and lists and lists of things, and how are you supposed to narrow that down in any sort of informed way?
Charlene, thank you. Maybe just to carry on with that theme of some of the vexing barriers, the big boulders that we need to move to enable more effective consumer choice in healthcare. Charlene, you commented on some of those barriers around keeping it simple and so forth. Other observations?
One challenge we have, and we see across the board, is, and it seems like it would be simple, but it's not. But maybe some people in this audience can help with it. It's today the populations that we serve is mostly Medicaid, and a good proportion of the people that we serve are multicultural. So they're very comfortable with SMS texting. That's the way they want to be communicated with, because they use WhatsApp to communicate with their families elsewhere. They're just very comfortable with it. That makes them really no different than the people in this room. I suspect that everyone here, for the most part, communicates now via text message. When people call you, you're like, whoa, who's calling me? I know people who won't pick up the phone at all. We communicate, our lives have changed, and we communicate by text message. Today in America, most health plans won't allow text messaging because of the TCPA, the telephone, the Consumer Protection Act that says basically that first text message you have to have been given permission to text someone. So think about this: the only way you can communicate with people that they're gonna want to be communicated with and engaged is a text message. And most plans in America today don't do it. People are just like in California, the largest public plan just did their first RFP for text messaging. There's another large plan, I won't say the name, very large plan that we're going to be the first time they're going to start doing text messaging. That's pretty crazy. It's 2018. So this is an example of a policy, this is actually a law, that just hasn't kept up, and we need to see change there because it's really holding back our ability to engage. If you can't engage with people, you're never going to have the kind of success that we all want. One example.
Jean?
Yeah, so a couple of things. First of all, I would say one of the areas that we hope to partner with CMS on is some of the regulations that have been passed over the years, which may be more constraining in the current environment, things like benefit uniformity and limits on member incentives. While they were put in place for very good reasons, and that is to prevent the bad actors out there, given everything that we've talked about today, I think there's an opportunity for a loosening up of some of those requirements. The other roadblock that I would highlight is one that's a little more self-inflicted, and that is an overabundance of member communication. So we talked about a number of things today, but when you think about all the things that we have to send to our members, our consumers, for regulatory reasons, so we have to get those out the door.
Yeah.
And then there's all the very basic block and tackling types of things like explanation of benefits and ID cards and member booklets and so forth. That's another whole tranche of communications. And now we're into all these campaigns to try to motivate consumers to engage and improve their health outcomes. It's actually overwhelming. We actually completed an inventory recently of all the communications that we send out to our members, and it's not surprising that they don't know what to do. It's very overwhelming. And so one of the things that we are doing is stepping back and trying to map out the journey of a member and looking at communication from the member's eyes to say, how can we streamline and simplify this? Are there things that we can combine together? Are there things we can eliminate? But really try to make it easier so that when we do send things, it's impactful and they'll pay attention to it.
Interesting. Charlene, others you wanted to
I'll
add?
just add a couple of things to that. I think building on the flexibility and also Krishna's point that the financial incentive, these little $10 gift cards are only going to get you short-term change. You know, what we've been hearing from some of the stakeholders we've been talking to and also what we know from behavioral economics is that also thinking about building in other sustainable mechanisms of engagement, namely the social incentives or building on people's already existing social networks, especially in the MCOs that we've been speaking to, we are seeing that happening already. They're saying things like the financial incentive got the member in the door, but it was the social incentives that we were giving them that really kept them in the program and engaged. And then I think the second roadblock is just that there's really a lack of enough rigorous evaluation to know what's working. Again, going back to these incentive programs, we were expecting to hear that there hadn't been a lot of evaluation. I think the degree of sort of guessing that plans and that states have been disclosing to us when they were designing and implementing these programs was more than we would have guessed. And certainly many of them are very anxious to do evaluation, but they don't have the capacity to do so.
This is a bit scary. I think Charlene and I were twins in a prior life. Every time I've got my next question, and you lead off with it. So where my head was going was, wow, this is really hard. We're trying a bunch of things. Is any of this working? So any evidence of impact, or is it still, Shubham's point, it's sort of the first or second innings? I never know American sports. I think that's where fat men waddle around a field. I think it's whatever the right metaphor is here. But it's early on in the, yeah.
But I think one thing that I would say in terms of some of the impacts, we do try to measure impacts, but to your point, it's sometimes difficult. And one of the biggest challenges we have is the fact that very often the same measure is being worked on by various initiatives. So if you take, for instance, reducing the use of emergency rooms or reducing hospital readmissions, we don't have just one initiative going on at any point in time. There are a series of them. And so how much do you attribute to each of those initiatives? So one of the approaches that we have taken is to try to look at sort of the total cost of care, not try to split the baby between the different initiatives, but to say we have a series of initiatives that we're implementing. They were intended to move the needle on these metrics, and are we seeing that happen? But without trying to pin it on any one initiative, because that gets really hard to do.
Declare victory.
Yeah, exactly.
It's working,
Yes,
it's working.
exactly.
Celebrate, salute that, keep going, yeah.
I think that underlying these comments are really how do we treat the patient more like a consumer? Because what you just described it's really how do we create a consumer experience so that it is beautiful? I took an Uber here, and it was just, I was sharing earlier with Charlene, it was so beautiful. No one had to teach me how to use it. It's intuitive. It's just a beautiful experience. I go back to it because it's beautiful and I like it. No one has to beg me to use Uber. I think that we all share that goal of how do we make the patient experience more like that, because it's not like that at all now. We're nowhere near that kind of beautiful consumer type of experience. So I think the first thing that's really good about this conference and others is that we're acknowledging that. We're saying we got to move to we got to look at what Netflix is doing and Uber and Airbnb and Amazon. They're doing something to make it so beautiful to use their services. We're not there, and I think acknowledging that and start to figure out how we can take the steps to get there is an important part of the solution. I just mentioned that I think the star ratings that you mentioned and the HEDIS measures on the Medicaid side, this is just our experience. I think they are really powerful tools for creating positive change because they're forcing the plans to get creative and to figure out how to get those star ratings up or how to get their HEDIS measures up. So I think that those two, not only are they powerful now, I think they have the potential to be really powerful drivers going forward of improving healthcare. And if we could do one thing that would be even better, I hope you don't mind me saying this, but if we could figure out a way to report them, not just aggregates, but like if Hispanics are not getting good care, we don't know. It's hard to figure that out now. And so it'd be great if we could know that Hispanics in a given area or for a given plan are just they're not getting the kind of care that everybody else is getting in the plan. It's hard for us to know that now, but if we could tease that out, that would be really helpful, and it would make those clinical quality measures even more powerful levers for driving innovation, which I think ultimately creates a more consumer approach to healthcare.
Shirley, when you think about the exchanges you mentioned, and you think of a lot of the work that's been done, I think on employer-sponsored healthcare as well as some of the government-sponsored programs around transparency. So I think we all get the theory of the case. There's more and more cost sharing. So if all of a sudden it's a bunch of it's on my back, I'd like to be able to make an informed choice. So then how do you actually get folks to know that there's a website or a tool of some kind that you can actually go on? Then how do you make sure that it actually has information, news you can use, right, on cost, quality, and service, because it's value. It's not just cheap and crappy is not the proposition, right? It's like, what's going to be the best value? And then you actually get them on there, and then, oh, you need 10 PhDs to understand the quality metrics, and like that's totally impossible. And then, oh, by the way, if you get through that, because you got some fancy PhD friend that can explain all that, actually changing the decision you would have made based on just like there's a lot there to actually get to the impact of better value, more affordable quality. Any thoughts on kind of where we are on the arc of that magnificent, joyous trip, and whether we'll ever get there?
So I will say, on an optimistic note, you know, where we started in the first OEP to where we've come now is leaps and bounds. I mean, first of all, in the first OEP, obviously, we were just trying to get something up that was technically working. But there was very little available at that time that was really there, which was really built to support consumers in doing that sort of side-by-side cost comparison and shopping. We have seen increased adoption that we've documented over the last several OEPs, that more of them are adopting, for example, these out-of-pocket estimators. However, we have in the fourth OEP, we did an out-of-pocket estimator comparison across some of the public and private exchanges, and similar to what we saw in some of the price transparency websites. So again, very sort of questionable what numbers you should be trusting, because these different sites were ranging from $1,900 to $3,900 for on the same plan for the same patient. You know, I made up a standardized sort of common patient. And so you wonder what the algorithms are that are underlying the different cost estimators that have been generated. What data source are they using for those? But at least I think there has been movement in the right direction. Another example that I can give is that in the first OEP, I think almost all of the websites besides one listed plans in order of premium, which, as you all probably know, tends to make people focus on that premium number and forget about that there could be substantial cost sharing. In the fourth OEP, for the first time, we saw that flip, and a minority of the public exchanges were using the premium as their default order of plans, and instead were using things like the total out-of-pocket estimator. Whether that was accurate or not, we had other states that were being more creative, looking at best fit for consumer, where they could put in what sort of attributes of plans they were looking for. And then we saw even more creative on the exchanges that were run by private companies. So, for example, some of them actually were calling out a plan that was recommended. They had different flags that said recommended, cheap, best network, to help guide consumers in this very complex and difficult choice.
Any experiences, Jean, with all of your efforts across the markets?
Yeah, I would say in the area of price comparison or procedure comparison, one of the tools that we have found to be very helpful, and this is something that we actually introduced to the commercial markets first and then ported over to the ACA individual market, is a Vital Smart Shopper product, which is very intuitive. When you look at the screens, they actually make sense. And what it enables the person to do is to enter the procedure that they're having, and then it shows them by facility what the cost would be. And built into this is an incentive, so that if they choose a lower cost facility, they will actually get an incentive payment for choosing the lower cost facility. And speaking of consumer friendly, it actually is very easy to use. You don't need a PhD, but it can lead the consumer to start thinking about some of the things that we all want them to be thinking about as they're making decisions. You know, procedures that could be done in a hospital versus a surgery center, or, infusion drugs that could be administered in a hospital, in a doctor's office, or in the convenience of the patient's own home. So getting them to think about those things and start making smarter consumer decisions.
Anything you wanted to add on that one?
No.
Yeah. So I'll maybe pose one other question, and then if you want to start to queue up the questions that you'd like to get in here, we'll turn to the audience. So lots of important work underway. Any thoughts at all around whether or not payers and providers occupy the right place in the value chain to actually earn the trust from consumers to provide them this kind of information to help them navigate and make
That's a tough one.
intelligent, smart choices? Or are you guys all like Darth Vader, evil empire, and we need some other Google, whatever, some people trust to jump in here and provide a lot of the infrastructure that would help navigation?
Yeah, well, I'll take a stab at this first. One of the things I did not mention about Highmark in the beginning is that we're a little different than some of the other payers because we're actually an integrated financing and delivery system. So in Western Pennsylvania, not only are we the but we also own the delivery system. We have 8 hospitals, 6 surgery centers, 4 health and wellness pavilions, and about 2,800 physicians. So we see both sides of the picture. And that's actually been very helpful because one of the things that we have been working on is trying to figure out how do we solve some of the issues that we've been talking about here today with both a payer and a provider hat on at the same time. And I will tell you, there is natural tension there. There are ideas that get put on the table where one side or the other has a vested interest, but it enables us to sort of work through this. The idea then is to then work this sort of within the family and then port it out to other strategic provider partnerships that we have across our footprint. So I do think there is an opportunity for all of the stakeholders, payers, providers, regulators, et cetera, to work together to solve these problems because we all own a piece of the puzzle.
Charlene?
Yeah, I will say, I am working with Google on a large precision medicine study.
Uh-oh.
And I will say that their UX or their user experience research is pretty amazing compared to, what we do, I think, typically within the healthcare sector. However, they also, still struggle out how to empower people with their own data and give it back in a way that is understandable. That's part of the work that I'm doing with them. I will also say, and I'm totally biased because I am a primary care pediatrician, and I do feel like I have a level of trust built up with my patients. And in fact, and we also were hearing this in the Medicaid incentive space, and I think particularly for these difficult to reach populations, having an in and the stakeholders were saying we really do rely on our provider groups a lot because you have people who are coming in, they trust hearing from you, and particularly within the Medicaid space, those that are either MCO or not, they said they don't feel like they really have a relationship with the consumer. And really the relationship with the consumer is with the provider. So I think really engaging wisely with providers in this space is really critical.
So a lot of this is helping arm them with the information that would allow them to then help the member, patient, consumer make the navigation, make the choices. Yeah.
I think one of the things that we're seeing a lot of is that those groups becoming more like what you've just described, more integrated. So we're seeing provider groups and the plans sharing risk, one buying the other, other players coming in. So it seems like there's a lot more integration going on, and I think that's going to speed up as we move forward. And the example people talk about is CVS buying Aetna, but that's just one example. It's happening in so many different places. So I think that given that's the direction things are going, maybe it's more about who's going to build trust with the patient. It doesn't matter really whether it's the plan or the or in a sense, because if they're all the same people, then from the patient's perspective, it really doesn't matter. So I think the key, again, is how do you build that trust with the patient and build a relationship with the patient that really allows you to move forward and to improve their health care. And I'll just bring up one thing that I think could be a really important factor in that. And that is, and I'm seeing it with a lot of plans now are doing it, they're bringing in the social determinants of health. They're recognizing that your health care is, depending on who you listen to, the actual health care is maybe 20-30% of your actual health. The biggest majority of what determines your life expectancy and your health are these other factors. And so more and more plans are starting to address that. It's hard to do, it's hard work, but they're starting to. And I think that as plans and providers start to look at the patient as a whole person, you're a whole person. You've got all these issues in your life, and we care about all of them, not just one part, not just the part I'm going to give you a shot or give you a pill, but I care about the fact that you've got housing challenges or food challenges or all the other things in your life. So I think as we move in that direction, that is a way we're going to see the trust factor go up. And I think when that happens, you'll see better outcomes overall.
This is, I think, a really fascinating point. One of the organizations I've always admired is Montefiore. And so you think of all the work that they do in the Bronx, in New York City, so dense urban environment. 85% of what they do is Medicaid and Medicare. And when they innovated their care management organization a couple of decades ago, it was really trying to make sure that as members joined, they get a whole person view of what they're facing. So do you have access to secure housing? Do you have violence in the home? Do you have safe sex? Like really trying to get at the real questions that would really have an impact on there. And what they found was it was really important to have people from the community that actually would build up the trust. And even some of the work they're able to do telephone, not just in person, to try to get some of this information and really bring in the social determinants, I think is a really powerful point here. We have a few minutes left, and I want to make sure that we had time for questions from the audience. So please feel free to ask a question, or if you don't have a question, ask the question that your best friend would want you to ask. We've got a microphone. Sir, perhaps just say your name.
Hi, I'm Reza Alavi. I'm part of DeVita Medical Group. I do healthcare consulting. One of the questions I have, I mean, thanks for the wonderful conversation around data and understanding consumer behavior and patient behavior. Are there really any good examples of going beyond clinical data and claims data to really understand and categorize patients and their behavior? If you think of Amazon now has credit card information beyond just your searches and what you buy, but they now have their own credit card. Now they're fully understanding what you do outside of Amazon, right? Are there other opportunities to get other types of data, link it with clinical and claims data to better understand patients, what motivates them, what drives their behavior, how to engage them, and so on, that are out there that we're not doing?
Fantastic question. Thank you. Any thoughts?
Yeah, I'll start off. There actually are a number of ways to do that. Both health plans through their own data analytics organizations, as well as a number of vendors in the industry, are actually combining data, literally hundreds of sources. A lot of consumer data on top of the lab data, the medical records, and then the claim data. And they are churning that around and then displaying it out. And usually what it's used for is in care management. So it actually takes the data and displays actions to the nurse based upon the in-depth understanding of that individual, like how best to approach them, how to engage with them, what to focus on, what the priorities are. So that is being used throughout the industry today.
I just add that I think that there's that area of big interest. I talk to a lot of other entrepreneurs. We've got a group called Health Tech for Medicaid, and we're very interested in innovation in the Medicaid space and encouraging innovation. We need new ideas. Medicaid, 1 in 5, Americans are on Medicaid. The program is only going to grow, regardless of what. It's only going to grow. There are ballot initiatives. I think 3 on the ballot, 3 or 4 this coming fall in red states. And you just saw what happened in Maine. They're being approved everywhere. So Medicaid is only going to grow. So we need new solutions because the current solutions just aren't good enough. We aren't getting the kind of results we want. So I would encourage policymakers to also, how do we make the innovations group at CMS, how do we give it more funding? And how do we encourage states to do more at the state level? Because Medicaid is really 50 different programs. There is not enough innovation in the Medicaid space. So there are some companies who are doing what you ask about, but not nearly enough. The future is bright if we can get smart people innovating in this space.
Charlie, what have you seen?
Yeah, so I'll just add, that study that I mentioned with Google, it's called Project Baseline, and it is doing just that, trying to establish a baseline of human health, measuring all different types of measures about 10,000 people, so clinical, imaging, routine, all the molecular data, a ton of behavioral, sort of patient-reported electronic and such captured outcomes, wearable device data. And so I think, certainly the algorithms for doing that are still needed. I would just make a second plug is I would love to have that sort of tailoring data, that sort of phenotyping when I'm providing care to patients. And I think that's certainly steps away still, but I think that would be very useful eventually.
Excellent. Thank you. Other questions? Please.
terrific and engaging panel. I think a good advertisement for inclusion riders, so I thank you for that. My name's Claire Pierce-Roble, and I'm with the Healthcare Transformation Task Force, and we're a multi-sector group that's looking at trying to advance more value-based care in the industry-wide. And I think one of the conversations we have between our provider and our patient members is that the patient groups seem to have a pretty good sense of what consumers want, and the provider groups seem to have a pretty good sense of the choices that they want consumers to make better. And I guess where they seem to not be meeting is actually enabling those consumer choices, or in some cases, maybe getting out of the way. And so I'd just be curious, because I think we've talked a little bit in this panel, mostly on the payer side.
Yeah.
And just curious from this group, what's kind of the number one thing you would like to see providers do differently to help enable better consumer choices?
Great question. Thank you very much.
I can start. So I think you need to listen to the consumer and learn from the consumer. I mean, this is certainly something that I've seen in my own work, and also when we were talking with these Medicaid stakeholders. I think, again, particularly when you're working with a population that is very different from the seat you sit in, like the Medicaid population, for many of the people who are doing work with Medicaid, it's really important to go and talk with them and hear what it is that they want, so you can incorporate that as you're developing your different programs. Something very simple.
And I would add to that also, being able to provide a comprehensive view of a particular treatment to the consumer. So being able to lay out, for this particular diagnosis, here are the different treatment options, here are the pros and cons, here are the cost implications. I don't think we do enough of that, but that would go a long way toward helping the consumer to actually get engaged and feel like they have a decision-making role in the process.
I just echo what both the other panelists said, which is, and I love the fact that we're using the term consumer, to treat patients like consumer. We've got to take off the medical hat and put on I guess you'd call it the marketing hat or the or business type hat, and treat people like they are consumers, like they are a whole person. And I think when we do that, you'll be amazed at how much we'll learn about what they want, because they will tell you if we're open to it. They'll share with you what their desires are, what their needs are, what they want, and what they don't like. But we've got to be open to hearing it.
Charlene, Jean, Abner, thank you very, very much. I learned a ton today. Thank you.
Thank you all, David, for a great panel. I'd like to ask our next panel to come on up. As you heard from Abner, Jean, and Charlene, it's not just about, consumerism is not just about deductibles and gift cards, but really about providing more comprehensive support and a much better consumer integrated, consumer focused and integrated experience. And that does extend to designing benefits and the financial side, but in a more fundamental way. This panel is entitled Changing the Rule of the Game, Next Generation Product Design, or Value-Based Insurance Design, which really is about more of that alignment on the benefit side with some of the changes in provider payment, some of the desired changes in care delivery that you've been hearing about today, all aiming to empower and support effective and efficient consumer experiences. To moderate this panel is Anish Krishna, who's a partner at McKinsey Silicon Valley office, where he focuses on strategy, transformations, merger and acquisition in the payer space, as well as care delivery strategy and consumer transformations in the provider space. He's had some extensive experience in this area, great preparation for this panel. I know if you all look at the clock, we are running a little bit tight on. This is a very efficient and eloquent group, so I'm sure they're up to the task. Thank you all very much.
Thank you, Mark. So we have the pleasure of being the last panel for the day, and really thank this wonderful audience that is still very engaged. What I'd want to do is I'd want to introduce our panel, and then start off with a few questions, and then once again open it up to the audience as you have questions. So to my left is Dr. Mike Chernew, who is a professor of healthcare policy and the director of healthcare markets and regulations lab at Harvard Medical School. He's also a member Congressional Budget Office's panel of healthcare advisors and of the Institute of Medicine's Committee on National Statistics. He's also on the board of the Massachusetts Health Connector and currently co-editor of the American Journal of Managed Care and the Journal of Health Economics. So welcome, Mike. To his left, we have Dr. Rosenberg, who is a senior advisor at McKinsey in our Chicago office. He brings decades of experience in healthcare leadership and medical affairs. Previously, Alan was a vice president of medical and clinical pharmacy policy at Anthem, so has a lot of payer and pharmacy-related experience. And he's currently the board chair of RAC and serves on boards of National Headache Foundation and Just Medicine. He's also on several other government advisory boards. And last but not the least, we have Dr. Tara Bishop. Tara is a senior expert and medical director at McKinsey, where she oversees the clinical aspects of our product and leads the Clinical Center of Excellence. Prior to McKinsey, Tara was a professor at Cornell Medical School, where she directed quality improvement for the Department of Medicine. She's also a board-certified general internist. So I welcome all three of you to this panel. So the conversations today, we heard a lot about value-based insurance design or next-generation product design, ranging from very blunt instruments like high-deductible plans to more sophisticated ones. So what I'd want to do is start by requesting our panelists to talk a little bit about how they define next-generation product design. I'd like to start with Mike.
So maybe this is on. The simple answer is we are moving increasingly towards more nuanced design that tries to put the incentives on the consumer in the places where we think that consumers can act. So this came up in an earlier theme. You're not going to expect consumers in the trauma center to make a lot of decisions. You're going to worry if they're in a high deductible plan that they get over the deductible, as Mark said, and they're going to be able to act, but there won't be any incentives there. So I think we're going to move to things like tiered network, although we've had a slide on that. Narrow networks are strong, and I'll explain why I think that might be moving more quickly than tiered network. Reference pricing hasn't been mentioned a lot, but that puts the incentive directly to where you think the consumer can make choices. I do a lot of work on value-based insurance design, which I will discuss later, but I think that's sort of where we've been. I think where we hopefully will be going is to coordinate that more with payment reform, a topic perhaps for later discussion, and some of the things that I would like to see happen would be things like getting rid of deductibles and making things mostly a co-pay only system. The deductibles drive everybody effing crazy. Can I say effing? Am I on TV? I meant freaking. In any case, it's very complicated the way it works out. And if we just, co-insurance drives people crazy too. That was cleaner. But anyway, it remains true. So I think a simpler price system. The other thing, and I think we're a longer way from this point for technical reasons, is I'll call it bundled-based pricing. So if you think you're going to get a price for a knee replacement, colonoscopy or something, the problem is there's not, or tonsillectomy came up in the last panel. It turns out the hospital can tell you exactly what you're going to pay if you go to the hospital, but you care about what you're going to pay for the whole thing. It turns out that the hospital is not the only entity involved. There's the physician. For some things, there could be an anesthesiologist. There could be 3 physicians. You don't care paying just to the hospital. You want some bundle or episode version of what you're going to pay. And thinking through a copay system that could get that level of simplicity would be important. And I think we're ways off. But luckily, the Highmark people will do it. I don't know where they went, but there you go.
Wonderful. Alan?
So, first, given the prior moderator's introduction regarding, he was the one white guy on the panel, and I think Michael qualifies for that. I'm not sure what my role on this panel is. But having said that, regarding next generation and value-based programs, from lots of years in the insurance industry, I sort of see value-based as sort of 2 sets of contracts that the payer organizations really manage. One is the insurance contracts. Those insurance contracts are between and dictate the members' benefits. And the other second large group of contracts are the provider contracts. So we can parse the words here, but I tend to think of value-based provider performance as separate from insurance design and focus the value-based insurance design on the insurance structure of the benefit plans. Words, and we can, sit and discuss them. I know Dr. McClellan in a major paper sort of focused more on the provider payment reforms. And they're very important. They're not totally separate. But it's helpful, I think, to be clear about where your focus is in this. And in that context, I think there are two next generations, one that's likely to happen and one that I'm not sure will happen in the U.S. The one next generation is broader implementation of many of those programs that already exist today. Right now we have mostly fairly narrow specific programs. So when CalPERS, put out their value-based contract that set a limit for certain types of procedures, single joint procedures, and if you went to institutions that cost more than that, the individual member was then financially responsible. I think we may see that expand. They've expanded beyond single joint replacement to a variety of other site of service, and we've historically limited hospital inpatient care, but there's expansions in that in terms of benefit plans and requiring it to be at lower cost sites of service. So that's, I think, a lot of this expansion of what already exists, what I call the actual implementation of a lot of the ideas that are already out there as the next generation. I think the one that's actually potentially more impactful and interesting, but not sure that our citizenry or our insurers or anyone else have the stomach for it, is actually evaluating the value in a strict quality per cost, British cost per quality sort of concept, and building insurance plans, whether you do it through thresholds. I could show you an insurance plan that said for new therapies that cost more than $100,000 per quality of life year, and another one that for benefits for things that cost more than $150,000 or more, they're not covered. Actually rationalizing health care. That would be another, or just packaging. We're going to limit what we cover in terms of services, sort of an Medicaid program of listing, these are the services. We've got a panel that have decided within the budget, it's an Australian pharmacy approach within a budget, and actually limiting to things that have real marginal value. But the marginal value comes at such cost that the value may be relatively low value. So those are the two types of next generation products I see.
Wonderful. That does spark a couple of comments, but I'll go to Tara and then we'll pick some of those up. Tara.
Sure. So just to echo my two colleagues here, Mike and Alan, I think when I think about next generation product design or value-based insurance design, it is that concept of how do you align what a consumer or patient bears risk on with what the rest of the system is happening in the rest of the system. So in the past 10, 15 years, we've witnessed an explosion of alignment and moving alignment to between payers and providers with the whole push to have more payment for value rather than volume. The same concept can be, I think, translated to the consumer experience. And I think we are just starting to see the tip of the iceberg there. I think everyone in this room would probably agree if we can actually align incentives across the value spectrum of patients to payers to providers, we will start to actually see more value in healthcare and less volume, less unnecessary services, more high-value services. So when I think about next-generation product design, it's really that idea of how do we align what a patient is experiencing with all of the value that we know in healthcare. And I think Shubham gave a good example of product being very much in this right now in this day and age of almost like a two-tiered system of things that are very fully covered, the traditional system of high premiums, low deductibles, a lot gets covered, to what was introduced about 20 years ago, which is consumer-directed high deductible health plans, where you have high deductibles and lower premiums, but not a lot of nuance in between those two. And I think we're really at a tipping point. Alan alluded to what's going on in California with reference pricing for joint replacements, with the idea of lower copays for services. There's a lot of kind of, I think, incremental aspects, but I think there's a lot of opportunity in the upcoming years and decades to really align what the consumer pays out of their own pocket with the value of services. So I think there's a lot in between the two products that are the leading products in the market now.
Wonderful. Actually, one of the things all of you commented on was there is the product design side, and then there is the incentives on the value-based insurance payment, and the two need to come together. So I'd love for you all to comment on how do you see that, or you don't see it, coming together, areas that need to be removed for those two things to complement each other. And maybe we'll start with Alan and then go to Tara and then Mike.
I think it's a surprise in there, but it's fine. I think, reference pricing and episode of care tie together. One is for the pricing for a hip replacement, but if I say this is all I'm paying in our provider contracts for a comprehensive form of care, then the value-based, what I require my members as an insurer to choose becomes less significant as long as everybody has accepted that comprehensive payment package. So I think they tie together in several ways, and I think that both being used to try to drive effective, efficient health care. I think one of the things that, from an insurance perspective, we're going to deal with is these tremendously expensive therapies, gene replacement therapy. First one came out, Luxturna, for this rare form of congenital blindness, almost $1 million per child with this condition. And there are a lot of them in the hopper now. And I think most of the payer models are excluding, they can't, even a fairly large provider group can't afford to be hit with these types of costs. So I think you're going to see insurance design interface with provider payment models, but there's still going to be very real differences. Yeah, a lot of it interfaces around what, Mike, you and have worked on around encouraging high-value, low-cost services. We've heard in the prior panel, all the STAR measures and things like that to try to drive up and preventive services, those things. But I think there's a real difference between them, and so there'll be some interface, but we'll need both solutions.
Sarah, and then we'll come back to Mike.
So I'll give an example. I love the example of low back pain because it's very prevalent, it's very costly, and there's a lot of opportunity to shift site of care to think about the services that happen after someone has low back pain. So, given your question of how do we align perhaps the patient side of things with what's happening on the provider side of value-based payment. Low back pain is a great example, right? So a patient can come in, we know that there's a lot of evidence that a patient doesn't need an MRI right away, they don't need to go have back surgery, they don't need an injection, they may need some physical therapy, some pain control, some reassurance from their physician or whoever's providing their care, and what we've seen over the course of the past 5 to 10 years is that as you start to align some of the incentives with providers, there is a shift. I saw with my own primary care patients in my own medical center when I was practicing was was a really visible shift that as we became more aligned and taking on more risk, there were more incentives to get patients into lower cost care. So more ways to get patients to physical therapy, even radiologists calling me up and saying, you don't really need an MRI on this patient. Why don't you forego that? So a lot happening on the provider side. But on the flip side, I was also dealing with patients who came into the office and really demanded an MRI and said, I really need an MRI. I have back pain, and I need to get it. I need to get this done. And so that idea of what we're seeing this happening on the provider side, how do we now get to the patient and get them engaged enough to use the tools everyone has been talking about at this panel, to get them to start to think about how to converse with their physicians or their other providers on identifying the best value care and then getting them efficiently into that care. So I think we really are at a point where we're seeing it on the provider side and there's lots of opportunity on the patient side.
Mike, you've done a lot of work in this space. We'll love to you.
So I agree with Alan and Tara completely, although as an economist, I feel I need to be more dismal, so I'm going to give you some of the negative side. So I agree, bundled payment and reference pricing seem to go well together, and in a population-based payment world, the physicians now want people to use helpful if the patients aren't demanding more. Benefit design can help, no doubt, particularly if on low-value care. So sure. So here's what I think, here's what I think the biggest problem is. In most of these new payment models, you're trying to get the payment and the risk, frankly, to span providers and to span time. And when you give a consumer flexibility and consumerism, there's a tendency for consumers to possibly want to go outside of the system. So I'll give you an example and then a few other quick stories. So in my market, all the tiered networking is about keeping people away from partners. And partners is wonderful. My department chair's there. All the population-based payment department are keeping people inside of partners. It turns out if you're an employer, you can buy the tiered network product and then join the alternative quality contract. And so now the partners people have an incentive to do the total cost of care stuff, and you have an incentive to go to Mount Auburn or some other place. And if I'm an ACO or some other type of population-based risk thing, I don't want the people that I'm at risk for running around on their iPhone getting their care at CVS or whatever it is they're doing. Unless, of course, I get to keep some of the savings, but I might lose track of all those things that go on, and I'm worried about. Another related thing is, so it turns out in a lot of these models, saving money in post-acute is like the ATM for how you make money, because they're not you. So you basically, if you're a hospital, you want to save money from someone else, it's often the post-acute. So you want to be able to steer someone to maybe where you have a deal with the post-acute, but if the people are deciding based on their own, it's not clear the incentives are going to be aligned. And part of the problem is the organizations that are creating the incentives, the insurers or some other organization, and they're not necessarily aligned with the organization that's bearing the risk if you've put someone in some sort of population-based or even episode-based model. I think it's that coordination. I know of one large insurer, because of an NDA I can't say, who's trying to coordinate this a little bit better. It's that harmonization from the point of view of typically it's the insurer who's the one that's setting up the benefit design, or frankly the employer is setting up the benefit design with how the payment models work. And most employers that are the ones playing with benefit design have no space, a few Boeing, a few others, but very few of them have any real finger in the payment system. And until you have some harmonization between the actual people that are setting the benefit designs and the actual people that are setting the payment models, it's very hard to get to this harmonization. Although, again, did I mention I agree with Alan and Tara? There is the potential if they could do that. I just don't think we have the processes now to quite get us there. So we have a little work to do.
Wonderful. So, this leads me to the next question, which is, value-based insurance design or next generation products. They've been talked about for a while. In fact, since the early 2000s, we had Caterpillar and Pitney Bowes as employers who tried it. What is different about it now that this is going to take off, or we feel more optimistic about it? And I'd want to start with Tara to start your comments.
Sure. So it is interesting, right? I think the idea of value-based insurance design seemed like a relatively new concept, but when you look back and historically, it's not that new, right? 20 years ago, Bose and Caterpillar were doing these things. They were lowering copays and coinsurance for high-value medications for chronic diseases. And over the last 20 years, there's been lots of examples of reference pricing, lower copays, again, usually around pharma costs to encourage the use of high-value care. I think there are probably three factors, though, that I think are potential drivers of really rapid change in this area. The first is the idea that there is this hunger for value. We are still in an era of healthcare where we have a lot of unnecessary spending. Estimates of up to a third of healthcare costs are unnecessary. Employers, payers, everyone is looking for ways to reduce unnecessary healthcare costs, and we are. I think that people are looking for the next thing that can do that. The second thing that I think is driving this is the idea that we are going through, I think, a big cultural shift. The idea that, 15 years ago, if you asked me whether we would be shifting so much from a fee-for-service healthcare system to one that is more value-based, paying providers in an ACO kind of model, it would never even be on my radar. And now we are in an era where there's a big cultural shift in how we pay for healthcare and how we engage both providers and consumers. And I think that's actually really important because now people are expecting changes. And the idea that now we can actually engage consumers is maybe a ripe time. And then the third thing is, I think, technology. I didn't bring my smartphone up, but when you think about how much we could engage consumers with the technology that we have available for us, it is leaps and bounds different than the way things were just 5 years ago. And so if you are able to redirect a patient from an emergency room to an urgent care center, and they pay less by going to the urgent care center, and they have the tool to be able to know that ahead of time, that's a game changer. So I think there's a lot of things that are ripe for change. We'll see what my colleagues think about this, because I think there's optimism, but it's hardly a seal deal.
Alan, you've seen this space for a very long time, so would love to hear your thoughts on this.
I agree. Tempered enthusiasm is an appropriate to be. As you say, a long time. There's some programs that have been around for value-based insurance design for a lot longer even than the Pitney Buzz. The Centers of Excellence concepts around transplant with enhanced benefits for staying with family members, for family members staying, et cetera. There's some of the very early concepts of, by quality and outcome and cost, directing people to transplant centers, some of which might be farther away from home, but in exchange. So why now do I think it will be picked up more aggressively? There are two or three major drivers. One is the higher volume of high-cost services like transplants. I mean, now, most new biologics, sit out there at 50, 100,000, 200,000. We're about to see in the next 5 to 10 years probably significant additional gene replacement therapies like the ones mentioned for Leber's congenital amaurosis, the blindness, the form of childhood blindness, that's going to cost $1 million per therapy. You're talking about potentially, and I'm not putting a stretch number out there, actually, people might say, $100 billion additional costs per year over to $1 trillion over about a 15 to 20-year time period from some of these therapies, CAR T, et cetera. These are on top. These aren't replacement costs for most of them for things that already exist. These are new costs. So the continued escalation of healthcare costs, and the state governments in particular being pressured, so they may be some of the groups that are going to come up with additional constructs around value-based insurance design. And the last one, honestly, I think is in part the failure of the last great idea, transparency. The studies that are coming out show that, and while there are some people who actively go out and search for less expensive care, it's found to be a very small part of the population with a lot of the transparency efforts. So my cynical side says, the Hewitts, the Towers, others need new ideas to push, and they have come up with value-based insurance designs. Some of what's being proposed, single drug like Entresto, value-based to put into RFPs, are trivial and aren't going to really bend the cost curve. But there are substantive changes, and I think that's part of what's driving this as well, and why now.
Yeah, let me briefly build on what Alan said. As healthcare spending goes up, purchasers often look to shift costs onto workers, in part because most purchasers don't control anything about payment. So for an employer like us at Harvard, it turns out that benefit design is the only arrow in our quiver. There's some other clever analogy. But anyway, we can't do payment reform. We have to do benefit design. Traditional benefit designs are very blunt. You get really good things happening and really bad things happening. So this whole move to new benefit designs is to try and keep the good higher cost sharing and get rid of the bad things. In other words, protect people for the high value services and make them pay for the low value services. Let them pay not very much if they go to some providers, make them pay more if they go to the expensive providers. That combined with the technology that Tara mentioned, I think comes together to put us in a world where we have these new benefit designs, not so much because we didn't know what to do before, but because you don't really worry about a value-based design if the deductible is $500. If the deductible is $5,000, you really worry about making sure that people get access to their high-value services. If you don't have a super expensive drug, you don't worry a ton about what you're going to charge for that, and how you're going to deal with that. If you have a very expensive drug that doesn't give you a lot of value, then you want to put the cost sharing there. So I think that's really what's motivating a lot of this, is the need to charge patients more and the desire to do it in a smarter way.
Wonderful. So some of the themes I'm picking up from this is, obviously rising costs. The costs continue to rise, and there's a lot of pressure. Technology has changed, evolved over the years. We have, better tools to be able to do some of the payment stuff that you talked about around bundles and so forth. There is a demand for transparency. I think that's, pretty clear. We heard from a lot of other conversations. And I think the other thing is the traditional tools haven't really worked, to your point earlier, which is the blunt instruments of a high deductible health plan or, a copay, et cetera, are just not working. So there's a desire to do something new. With that lens in mind, what I want to focus on, or this is a question for the panelists, is talking about some real-world examples. And I know, Mike, you've been implementing some of this at Harvard, so would love to hear your thoughts on, what shape, way, or form is value-based, insurance design being
So I
implemented?
should say trying to, but I appreciate your prescient notion, come back and we will have. We've struggled for a bunch of reasons. The adjudication system to work with our insurance. First place we go is talk to our carriers, and you realize you can't do anything if they can't adjudicate it. The communication issues are a real challenge. We've tried tiered networking. We didn't quite get that through. We tried reference. The Vitals actually is on our list of things that we're looking at now. Now, why we need to buy a third-party vendor with its own administrative costs to come in and help us steer people in ways as opposed to just setting up our vendor system with rewards, that's a separate question. But I think the challenge has been that, again, we don't control benefit design, our carriers do, and even then, we might want a free ride and not have to pay the bonuses. So we're stuck with benefit design, and it turns out because of some of the technical issues with our carriers and some of the communication issues with our workers, we have really struggled to find those types of programs that makes things really very simple. So hopefully we'll get there. We're not there yet.
Alan, you've, I'm sure seen some successful implementations of these products. Would love for you to share some of those examples.
Well, I referred to, CalPERS was a major example, and the expansion. And CalPERS really were two different constructs within the same general plan. One was this, reference-based pricing, so that paid up to X dollar amount, and after that, people, you were responsible for anything above that amount. And places like Stanford and other leading institutions fell within the reference-based pricing, so it wasn't the cheapest institutions. And it worked, and the other institutions fairly rapidly brought their price down. That's one of the few times you see a significant impact on pricing across a broad set of institutions. They also, we've implemented, the past week, because I'm no longer part of Anthem, but Anthem and other organizations have done a lot of site of care programs. So to try to, in terms of value-based, but it's value of having an infusion in a hospital-owned infusion center versus a freestanding independent infusion center isn't any greater. I mean, what's infused is the same, the amount, the complication rates are the same, et cetera. We're just not going to pay for the extremely higher cost structure of the infusions. And the cost is really for the drug costs in those, and that has to do more with contracts. But another example of a significant program implemented. I think one that you probably don't think of in value-based, but is the move to far more step edits and prior auth requirements for both pharmacy benefit drugs and drugs covered under the medical benefits, so that where there are two equivalent forms of a therapy, to move and require A before B is another form of value-based insurance design. And copays in that domain, if you think about drugs that cost $50,000 a year, $100,000, copays don't have an effect, particularly now that copay forgiveness cards are fairly standard for many drugs. And so that whole copay driving concept, co-insurance driving concept has gone away. So you now have much more aggressive implementation in terms of value-based steering by putting in formularies far more extensive rules around use of lower value drugs.
Wonderful, thank you. And Tara, I know you've been working a lot with employers and payers, focusing on helping them think through some of these. So, any examples that stand out that you've come across?
So I think, we could say CalPERS again. So I think there are these examples of what I would say are kind of incremental value-based insurance designs. So the idea that you could have reference pricing for a few key procedures, or you could have variable copays for different medications. When I think about the particularly purchasers and employers that we have worked with, I think there are probably two themes that really stand out to me. The first is the idea of what is the value on the table, and I think there is a level of skepticism with the current design of value-based insurance that we're actually going to pay for more by having lower copays for high-value services, and that the incremental benefit from a cost perspective happens down the line. And I think that's a little bit challenging, right? In an environment where it's unclear whether you will have the same patients 2-3 years down the line. So that idea of what is a value proposition and what is a value on the table, I think needs to be really laid out. The second idea is how do we make it easy for patients? I have spoken with numerous employers who say, I just don't, my employees will understand this. They will get a surprise bill. They will come calling me with lots of questions. And so we do have to get over the idea of how do we make this easy, simple, transparent in a way that is not a CPT code that a patient doesn't understand, but is, I have the sniffles, where's the cheapest way that I can get care for those sniffles? And so I think there are two kind of key areas that I see employers asking about. How do we get value how do we get value out of value-based insurance design, really from a cost perspective? And how do we make sure this is easy for our employees, our consumers to use?
Yeah. Mike, you wanted to add?
Well, I just wanted to say, I agree exactly with Tara said, and I wanted to add an experience from Harvard. We very much want our employees to pay more until actually we realize that means that they're going to have to pay more. Other than that, it's perfect. And I think the line from that is there are real limits to how much of consumerism. I'm an economist. I believe in free markets. I have some patriotic views, but anyway, whatever the point is, there's only so much you're going to do through benefit design, because fundamentally the risk protection part of insurance and the concern that employees won't make the right choices, they'll end up at the wrong place for whatever reason, because they didn't, and they'll get a big bill, and they're going to come back and complain, becomes a real impediment to moving forward really aggressively on some of the things that you would need to do if you were fundamentally doing this to save money. If you're doing this to promote value, great. If you're doing this to save money, employees are going to have to pay more, and it turns out that many employers actually don't want employees to pay more.
So I agree largely, Michael, but I think there are services which you just say aren't going to be covered. Either they're not medically necessary in this context, that they are low value and not covered. And then, under most contracts, those get stopped being used because either the provider is liable for the costs that they've incurred, or the member is, but they pre-cert these things ahead of time. So that is part of, I think, one of the reasons I suggest we need to be more explicit. That drives behavior dramatically when something's just not covered.
That's right. And when there's a tension between what the doctor says and what the benefit design says, usually the insurer ends up in the crosshairs, like the video of the person that had a, I don't know if they needed whatever they needed, and the insurer said it wasn't covered, but the reaction was, I needed this, and it wasn't paid for out of network, and now I got the surprise bill, and it was a scam in a whole bunch of ways. And that's the tension, which the videos showed stunningly well.
Wonderful. I know I've been given the time warning, so I'd want to open it up to the audience for any questions you might have at this point. Okay, if there are no questions, I'd close with one question for. Do we have one? There you go, Don.
I had a question to throw out on design, which is, it seems one of the problems is that by having annual renewal periods, we have products that have an annual time frame, which doesn't make a lot of sense with chronic illness and lifestyle modification. It seems like the absolute fundamental premise of what we're doing is deeply flawed, other than maybe some of the HMOs or the VA that have sort of longer time horizons. And I would be curious if folks thought about how do we get longer time thinking, right? It's not a product like a mortgage or, a longer term thing, or even most insurers in the non-healthcare world have incentives for, sticking with, whatever, State Farm, Allstate. I'm just curious if folks have thought about how we can formally get longer-term products that are more likely to incent successful behaviors, because most healthcare behaviors do not have a time frame of under 1 year.
Yeah, I mean, Dr. Lowe's concept of the mortgage, out of MIT, and very difficult. I actually asked, because I was part of trying to figure some of this out through a project, and our actuaries, and the reality is when they've tried to offer longer-term benefit plans for 3 years, 5 years, and you have to sign up, they've not been successful in the marketplace. And so you tie in premium revenue. I mean, that's really what an insurance product does, tries to spread, risk and takes premium revenue and expenses and match them. When you have these costs go out over 5, 10 years, very hard when it doesn't match up against premium revenue. So I've been thought about trying to come to solutions. A solution, it's a difficult one, would be for certain types of high-cost services, reinsurance pools that are required from a government perspective that everyone pay into, all the insurers, and then would cover these services. But you're not really talking about chronic care. You're talking more about single episode, high expense. Does that, I try to answer?
Yeah. So, first point I'd make is, apart from your health issues, on an annual basis is crazy, which is partly why I don't like deductibles. But that part aside, I agree with what Alan said, but even more broadly, the premise that better primary care, better prevention, or better you pick is going to actually save money if we just wait 5 years, I actually think is factually not correct. That most of those things simply don't save money over a longer of time. They're cost effective, they help you live longer, I'm all for them, I love my wife, my kids, my dog, but they don't, we should not do that type of stuff thinking we're going to pay, it's just going to save us a ton of money later on. And that's what I think the fundamental problem is, apart from all the administrative things that Alan mentioned.
All right.
I also think there may be some market segmentation. So, in a Medicare population where there isn't the churn of, a Medicaid population or a commercial population where you're tied to your employment, or an individual market, although probably less so, there may be opportunity to think about longer time horizons, the value that you get. And I agree. I mean, I don't know if we're saving I mean, there's been studies like, I don't know if we're saving a ton of money, but we're saving lives by some of the preventative care. But I do think some of the chronic disease care, keeping patients out of the hospital, preventing amputations, all sorts of downstream costs. I think it is going to be challenging in a commercial population, though, to have a 3 to 5 year horizon.
Yes.
One last question.
Okay, this is Neil Belson. As I said this morning, when I asked a question, I'm with Potomac Law Group, and following up on Dr. Rucker's point, and this is more of a general philosophical question. I mean, is the real problem with chronic care that thinking of in terms of insurance, quote unquote insurance, is really the wrong mindset when we're talking about long-term chronic care? Because normally insurance, I mean, the very definition of insurance is spreading uncertainty in exchange for a premium. And normally, like fire insurance, home insurance, catastrophic episodic insurance, there's no idea who's going to get illness. We know that there's going to be based on actuarial information, we know a small percentage of randomly unpredictable number of people are going to suffer catastrophic injury, and insurance basically alleviates the risk that you're going to be one of that unfortunate handful. But you have a chronic condition like cardiological problems or heart problems or diabetes. There's no unpredictability there. You know it's going to have to be managed long term, and is really insurance the right way to think of that?
So there is a lot of unpredictability in people. You take 100 diabetics or 100 people with cardiovascular disease.
Right.
There will be a lot of variability, but there'll be so you have there's ex ante risk, you have chronic condition or you don't.
Right.
And that's an issue about how we spread that across and pay for that, which the ACA had through rate bands and a bunch of other things. And then, but within any of those pools, there remains a lot of variability because of the people with cardiovascular disease. Some subset will have expensive heart attacks, some set won't, some will have but whatever the case is, so there's a lot of variability within all that chronic condition. So we have to deal with the risk that you become high risk. That's the multi-year problem. But even within any risk band, there will still be a lot of variability that you want to think through. And we just aren't sure how to deal with those two separate issues well.
And it would seem like would be a key part of whether someone goes from a condition to a much more serious condition.
Yeah, and Michael, your point's right on. I'd suggest a lot of American health insurance. I mean, preventive services, we know what we need. We know it's not unpredictable in any, and yet it has mandated first dollar coverage. A lot of what, quote, health insurance in the U.S. is a tax-preferred financing mechanism and a forced savings by employers, by others. I might say forced savings, I put it in quotes, but program so people have access to these. So it's not purely an insurance model.
Tara, any final comments?
No, just, I mean, to echo that, I think the idea that insurance is perhaps a misnomer. It's coverage, right? It's coverage for services, some of them catastrophic that are unpredictable, some of them that are just coverage for things that are part of our healthcare system. And I don't think we're in a phase where we are going to carve out everything that is not catastrophic and have that be the standard model. But I do think there's, again, as we discussed, opportunities to nuance in the design.
And the last thing is things that we didn't used to think of as catastrophic for most Americans. The cost of getting an MRI and a visit for a knee sprain, et cetera, can be pretty catastrophic compared to what their budgets allow. So part of this is how expensive healthcare has become.
Great, wonderful. So what I'm hearing from the panelists is there's a lot of opportunity, there's also a lot of challenges, and I think if I were to use 2 words to summarize it, it's cautious optimism is what we hear. Let's see when we reconvene next year where we are on this. So thank you so much, Tara, Alan, and Mike.
Thank you.
I want to thank all of the panelists too, Anish and his colleagues for an excellent job this afternoon. So we are a little bit over time. I'm going to be extremely brief. As you heard today, we touched on a lot of issues: insurance, predictable risk, care redesign, provider payment reform, data interoperability, and effective use. But where I think they all came together was our organizing theme around this transformation that seems to be happening, maybe at the early stages, of the role of consumers in healthcare. We obviously didn't answer and solve all of these problems today, but hopefully you learned a lot. I know I did. And I want to emphasize that our group at Duke, with our collaborators, people like Mike Chernew and others, our colleagues at McKinsey, are going to continue working in these areas, in addition to having access to the materials from this conference on our website. They'll be up and available for those of you here in the room and online. Please stay in touch with us and make sure you're on our mailing list about future events and activities in these areas. So last, just a few thanks. McKinsey, Anish Krishna, Shubham Singhai, Sinthu Arugaramgamam, Julie Lane, and colleagues who are all tremendously helpful in getting this work together. At Duke Margolis, Sarah Supsiri, Mark Jopinga, Ellen DeGraffenreid, Megan Moore, and especially thanks to all of you who joined us here today and online, and all of our panelists for a very interesting discussion. Thank you again, and safe travels. Take care.